The final day of the very wonderful event. So because, alhamdulillah, the 14th of August, our Independence Day, so we will start the proceedings with the national anthem. Whenever you're ready, and we will rise when we play the national anthem. And lots of people put the hand on the heart. There'll be some moving around of the sessions and talks because of various availability of various operators and the procedures going on in the lab. So we'll start off with Colonel Sajjad Ahmed. He's going to be talking about coil embolization of perforation. Sajjad Saab is a very keen interventional cardiologist in AFIC, and he has special interest in imaging. And his talks are very provocative and right, Sajjad Saab, are we on? Yeah, please.
Bismillahir Rahmanir Rahim. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Sir Bashir Hanif and everybody else here, thank you very much for having me here at this conference and speaking. Is the slide changer not working?
1973. 7th.
Yeah,
we
it's
need
working.
some panelists up here.
Okay,
so if I could deputize Harun Saab, Shehbaz Bhai, if you could come up as a panelist. Zubair Akramai, if you could please join us. Bashir Saab, would you care to join us? And then you have got so many commitments going on. And let's have a very heavy panel. So if you could join us. Yeah, Jabbar Saab, please join us. And Noman Saab, it will be such a pleasure to have you. We have more seats. And we wanted to have Ehtisham Mahmood Saab, but I don't see him here. Yeah. And Naeem Tahir Kheli. I wish we could have him as a panelist, but I think he's still there. He hasn't turned up. Yeah. And Parvez Miraj, Prag Doshi, and Tahir Hussain. They're very eminent guys. As they turn up, we'll invite them over.
Right, so first things first. My talk will be mostly centered around how to deal with embolization, coil embolization in terms of coronary perforation. So the first things first, how does coil embolization actually work? Now, if you look at this histopathology section, you can see that the C's mark where the coil has been deployed in a coronary vessel, the T's mark where the thrombus is actually formed. So the thrombus forms on top of that. Now, over a period of time, there is some degree of recanalization within this thrombus. For coil embolization, getting down to the basics of the hardware, so you need a microcatheter and you need the coils. So you need the coils to be deployed through the microcatheter. Now the microcatheters can either be dedicated from within the package, and sometimes you can use OTWs. As far as the coils are concerned, they could be made out of platinum, nitinol. There are two types. They can be detachable versus pushable, and they can be fibered versus non-fibered. Now, the detachable coils are can be used for optimal positioning, but that's mostly for structural heart disease specialists who would want exact placement within a PDA or another structure. If you use fibered coils, obviously they're more thrombogenic, so you tend to use less number of coils. That saves cost and time. Now, this is a study for nylon fibered versus non-fibered embolization coils, and this is from where the marketing actually began in terms of Cook's Medical. And if you look at this, you have two coils which are fibered and non-fibered, and the nylon fibers are actually 19 microns, and they're more thrombogenic. So if you look at the specimen on the left, and then there's one on the right. So if you look at the right specimen, that's non-fibered. You needed 4 coils, and you still had extensive degree of recanalization over a period of time, which means blood would still be flowing through. And a fibered coil, for a fibered coil, you would only need 1, and the areas of recanalization still would be far less. Now, there are different shapes and types of coils. Fibered coils can be straight. They can be helical. For example, this Nestor coil is available in different lengths and different diameters. So it's 0.018 or 0.035, and that would also determine the size of the microcatheter that you use. The Hilal coils are relatively straight, not actually a coil. And you have these tornado microcoils, which are 3x2 turns, which means that they taper down in the form of a spiral. For the microcatheters, you would use pro-grade fine cross cantata or OTW. It's just a reminder that when you use 0.018 coil, you've got to ensure that the delivery catheter has an internal diameter of 0.018 to 0.25. Just some pictures to show this is the cantata, and along with that, the Cook Medical Hilal coils. You have the Axiom EV3 and the Azure from Terumo. And this is how a detachable coil works. So you put in the coil, and then you attach this detaching assembly, press the button, and it gets released. And there you are, and the coil is deployed. Some tips and tricks. Firstly, ensure compatibility of the equipment. Make sure that the coil can fit in the right microcatheter. Get the microcath as distally as possible. Don't use the back end of a coronary guide wire. That's quite controversial because sometimes it can lead to perforation, but the advocates would say, look, we can see the radio opaque coil, so there's nothing to worry about if you're careful. And then there are certain techniques on how to do this. So excuse me for my drawing on this one, but the first is block and deliver. So usually you have a perforation on the first wire. You've got a blocking balloon. You inflate that induced balloon tamponade for the coronary perforation, deflate that for a second, take the wire down and take the secondary microcatheter down, and then reinflate the balloon. So now you've got the perforation blocked for a while, and you can work with the coil at the perforation. It's always desirable to induce dense packing, because if you have inadequate packing, that would lead to persistence of the perforation. In general, it's advisable to weave the coil, so you can only do that if you actually have a coil and not something straight like the Hilal from Cook's Medical. So you would actually need a coil, something that is curved. And as you deploy, you keep pulling back as if you're weaving. And then you have the scaffold technique, which means you use a relatively bigger coil with more space initially to form a scaffold, and then you use smaller coils. So for example, 0.035 first and 0.018 after that to fill in the spaces, and that would really make it a dense scaffold. Then you have the anchor technique. So if you've got a small side branch, you might want to push the coil initially in that. You would have to go super selective with your microcatheter in that, and then gradually weave out of that vessel, so that the coil gets really nicely anchored there. So this is a circumflex perforation, which is the type 5 perforation. I can't see, are they running? Yeah, okay, so you can see that distal perforation at the end of the circumflex for one. And then in the next frame, you can see that the tip of the microcatheter, which is marked by the blue arrow. Then we did a microcath injection to see that we are where we want to be. And then you push in the, you weave the coil through. Yes, left wali video chala sakte ho please? Can you run this video for me? No, this one. No. If you could go back a frame, I need to show the weaving. Can you just click on that? It was running a while ago. Just check. Anyway, so yeah. Oh, that's sad. We just weave through and we fill in that space and make it really dense, and this is kind of the final result that you have, and you see the perforation is sealed, but you see that the coils are nice and densely packed. Okay, that's it. Thank you. Thank you very much.
Any questions? It's a great technology, but one must realize that when you coil something, lots of times some different collaterals start to fill that bleeder also. So it's very important to identify, especially in retrograde PCI, to work out which is the feeding vessel to that perforation. And if you occlude the proximal portion and you end up with feeder from other vessel, that can be a real challenge after that. So.
The first and basic principle of managing any perforation would be, the moment you start managing a perforation, would be identify the precise site in multiple views, projections, and then also identify all the feeding vessels. So yes, you would move on from there. Thank you. Thank
you.
So if we can connect to RIC Cath Lab, and it's our pleasure to have online with us Dr. Tariq Abbas, who did that wonderful case for us, and Professor Bilal Murad, who's an amazing guy. He's a real, very regular visitor of Pakistan, and we've all learned a lot from him. I wonder if they're online so we can welcome. And Dr. Tahir Hussain.
Just one question I would like to ask, if you have a time. Talking about the coiling of distal vessel perforation or branch perforation, how effective is when you use subcutaneous fat? Sometimes you use
subcutaneous tissue
to block the perforation, especially in distal vessels or branches. And at the other end, you are also using the coiling is another way to stop it. Is there any study on it, or is there your own experiences which show how effective are both the techniques, and which technique is more effective?
If I could answer that, we're going to the Cath Lab, but just dedicated equipments are very effective. So you must use coils and pellets. If you don't have, then you can innovate with whatever you want. Like you need cover stents. If you don't have it, you make them. But the improvisation in the Cath Lab is never as good as the patented stuff. So we must have these patented coils and pellets with us. So I think I can see Asim all scrubbed up in the lab with his carotid. Welcome, Asim. Can you hear us? Please, can you connect us to RIC Cath Lab? We can't hear them. I can see he's all ready to go.
Yeah, I can hear you, Janaswet.
Assalamu alaikum, Dr. Asim. It's such a pleasure to have you.
Sir, thank you very much. We are very honored to do live cases for Pakistan Live. So welcome to Rawalpindi Institute of Cardiology. Is my voice loud and clear to you?
Yes, we can hear you very clearly. We can see you very nicely. It's a great quality picture, and your sound is perfect.
Excellent, sir. So I'm going to introduce my team first. I'm Dr. Asim Jabir, the interventional cardiologist, and next to me is Dr. Mohsin. He's an interventional cardiologist, and I'm being assisted by Ishtiaq, and on the machine is Awais, and our Cath nurse is Memuna. I'm going to ask Dr. Mohsin to introduce the case, and you have the slides for presentation in the hall, so you can see the slide as well.
Assalamu alaikum. Today our patient is a 65 years old hypertensive male who had recurrent TIAs in the last 10 days, and his carotid angiogram revealed a tight stenosis in the left internal carotid artery. We're going to move towards the carotid angio now and show you the images, and from there on, Rasim will take the case.
We'll show you what we've done so far, and then we'll take it on from there.
Great.
So what we've done is, go back please, go back, okay. So this is a 6-French system, and we're going to bring our SIM2 catheter in, so that's the way we do it. So we're going to shape the catheter in the ascending aorta, and next view please. So it works just like implant, so you pull it up, it
We
goes
can't
up.
seem to see the views. I think you're going a little fast for us. Can we have the latest views there? We can see Asim, but we can now see the monitor with the pulse of 66, but we can't see the views.
Can you see the screen, please? Okay, stop flashing, please. Can you see the screen now, sir?
We can see the still frame of the head.
Okay, so audio visual, can we please have the live photo image over here?
Can we fix it from here, or will they do it from there? So Asim, SIMS2 catheter is just to engage the catheter. It's not the guider itself. It's a diagnostic catheter.
Yes, sir. So SIM2 is a very nice catheter, and it really helps in difficult aortic arches. So you've got different ways to shape it either in the ascending aorta or through the subclavian artery. So, and it works just like an implant catheter. So you tend to pull it up, and it keeps going into the carotid, it goes up. And when you want to bring it down, you need to push the catheter. So it's a very nice catheter, very soft.
So excuse our ignorance, but when you say difficult cannulation or difficult arch, what do you mean by that?
So if you have a type 3 aortic arch, if you have a bovine arch, so SIM2 is quite easy to engage those from the femoral route, but of course, if you have a difficulty doing it with a SIM or a VTK catheter, then you need to change your approach and maybe go from the arm.
Okay.
So do you see our live fluoro now, sir?
We still can't see you live. Yes, now we can see you. We can see a
Now
DSA.
we can? Okay, let's go to the first image, please. Okay, so that's our SIM going into the non-culprit artery into the right side first. Next view, please. So we've taken a shot of the right, and you can see there's a carotid web at the right ICA ostium. Next view, please.
Are we still calling it a web, or is it an ulcerated plaque?
On the right, sir, on the right, this is a carotid web. You can we go one view back, please? Go one view back. So if you see here, it's like a pouch hanging outside the left internal carotid artery. So this is actually a pouch where the material tends to accumulate and can embolize, but this is not the culprit artery right now, so this is not our target. So let's go next, please. So now we're going to engage the left carotid, and that's our target for today. So you can see that there is a very critical osteal disease in the left internal carotid, and it seems to be like an ulcerated plaque, ruptured plaque here. So this is where we are. Our guide right now is a 6 French 90 centimeter destination sheath. And so we are ready to go in with the filter. So I'll quickly show how the filter is prepared. If you could kindly focus on my hands.
The destination sheath has an outer diameter of 6 French and the inner of a 7 French.
That's right, sir. So I'm going to de-air this is a NAV6 filter system that I'm using now.
Okay.
So you first de-air the whole system.
Oh, that's excellent. Are you going to prepare it in front of us?
Yes, I'm going to prepare it quickly.
Can we enlarge this preparation picture, please?
Can we zoom on this, please?
Can we have it on the main screen? Yes, that's excellent.
Okay, so yeah, good. So now you can see it nicely. So I'm going to de-air the whole system. I filled saline here. This is heparinized saline. The filter is submerged in this. And so this
If
is
we can have Dr.
how-
Amber Ashraf, Dr. Kamran, and Dr. Khawer, Dr. Khawer Kazmi, please join us for the panel. So what they're doing right now is to prepare the distal protection device. This is to
Yeah,
prevent
it's a-
embolization.
Right, sir. So once it's de-aired, then I'm going to pull this filter into the delivery system. I'm going to load it. So now it's all loaded. And I'm going to bring all of this system out now. Please hold this. So we bring it all together out. And we've got a
Dr. Saba?
peel-off sheet with it. Can we have this at the back, please? Thank you. So we're going to load this in the peel-away sheet. And we're going to shape the wire according to the size of the common carotid.
This is a fixed wire system which has a floppy wire at the end. You can shape it to direct it where you want to. And there's a filter or a distal protection device which once they cross, they will open it because there will be a lot of distal embolization during the manipulation of the plaque in the carotid, and that will embolize. And this is a very important way of protecting distal embolization, although it doesn't stop it altogether. But the current evidence suggests that the incidence of stroke with this device or any other distal protection currently is about 3%.
All right. So let's do a DSA now. Ready for DSA? Okay. System fill, please. All right, good. So let's do a DSA. Ready for DSA?
DSA being a digital subtraction and geography, it takes out the soft tissue shadows so you get a better picture, but it does take more radiation.
Roadmap, please. So in all peripheral interventions, this overlay or roadmap system makes your life very easy, makes things easier for you to work. Okay, so now we've got our roadmap here. So I'm going to take both the things together, the whole system. So give me the roadmap, please. The last view. Yeah, go to the last view. Okay, stop. Go back, frame back, please. Frame back. That's it. No, frame forward. Okay, that's it. Let's have a roadmap. Ready? Okay.
The vessel which has no branches in the neck is the internal carotid, and the one with branches is the external carotid. It becomes a bit confusing sometimes, which is which, but if there's any branch, then that makes it the external carotid.
Yeah, so we're just waiting for the roadmap. Give us a second, please. Give me the roadmap, please. Javed?
So, Dr. Tariq Abbas here from Oklahoma City. So,
Hello,
while he's
Naeem, how are you? Great to have you.
very good, Sohail. I just while you're waiting, I just wanted to give a couple of comments about this. Since we're talking about tips and tricks, one of the things, just whoever is starting, I found over the years that accessing the left common femoral gives you a straighter shot into the carotids as opposed to right. You're just taking an extra angle out. So when I do carotids, I exclusively do it from the left femoral. Not that you can't do it from right, just takes one out. And then the other thing is telescope.
Recording in progress.
The telescopic technique for your fellows who may not have done that, basically, we would take a 90 or 100 centimeter 8 French guide and have 125 centimeter 6 French or 5 French GR4 or AL or Sims 2 or Headhunter in there, and then that cannulates your carotid.
Show this.
And when your diagnostic is up there, you can just slide your guide in there too. So.
That's such a useful technique, Tahir, that I would tend to practice it always in all cases, because sometimes you think it's going to be easy cannulation, and you're stuck for a while. So if you always make it a habit, then you could become good at it, and it just makes it slick process, especially if you want to change it over to the railroad or the mother and child technique.
Yeah, so for my carotids, I size it before. I know what I'm going to do. I take everything out, have it basically ready to go to start with. And when I put the sheath in, after that, basically we do this telescope technique and immediately take the diagnostic out, and then right after 1, 2, 3, 4. So the idea is that everything is done in less than 10 minutes, but you prep everything beforehand. You decide what you're going to do before, pre-dill, post-dill, your stent size, and all that.
That's a very important tip, that for new programs, make sure that your inventory is right. The right carotid tends not to be a difficult problem in cannulation. It's basically with the left, especially with type 3 arch or a bovine arch. And that was new for me to have to do it from the left femoral, gets a better angulation. But average person, unless you use a Doppler technique, he does have more difficulty in cannulating the left femoral versus the right femoral. Yeah.
General Sohail, can you hear me?
Yes, we can hear you very well. We didn't want to disturb you, so we're having discussion. I hope we're not bothering you too much with our talk.
So I can't use a roadmap right now, but it's okay. I'll do it without that. So I've deployed my NAV6 filter. It is deployed in the distal segment of the straighter cervical segment of ICA, and I've got my balloon in position for dilatation. This is a 520 balloon. But before that, I've given atropine 1 milligram. I've waited for 1 minute. The heart rate is now around 102, so I'm good to go with the balloon. Just please show me where we are. Okay. No. Finish that, please. Finish that, please. Okay, give me a test, please. Okay, good.
What will you dilate? What size balloon will you dilate that with, Dr. Azam?
This is a 5 by 20. Okay, down, please. Store fluoro. Go down.
One thing to remember with carotid is you must undersize all your equipment and the end result. If you get a 1-to-1 like with carotid, there's a big chance of perforation, and you can get a hematoma in your neck, which can be suffocating, and that's a real disaster.
Go slowly up. Go slowly up. 4, 6, 8, 10, 12. Okay, and down, please. Store. So our earlier practice used to be very careful with the pre-dilatation, either avoid it or use a 2 millimeter balloon to do it. Just take a filter across, then put a stent in, leave maybe 30% waste behind, or post-dilate adequately after that. But I think a lot of studies have now shown that it's the post-dilatation which actually causes maximum distal embolization due to the cheese cutting effect. So now we prefer to use adequate pre-dilatation. So I've used a 520 to pre-dilate, and I hope that after this, after the stent deployment, I'll not have to post-dilate the stent. So I'm going to remove the balloon, take a DSA, and then we'll take a stent in.
Asim, there's no data, but I would tend to pre-dilate with a little smaller balloon. I thought it produced less embolization and vagal effects for me. Just a personal experience. I'm not sure if there's enough data.
Okay. Ready for DSA? Okay,
This is Dr. Hussain from Orlando. I just wanted to make one quick comment. This is a wonderful conference and beautiful work. We have done a case, pushing the limits on a 100-year-old patient for her carotid. Still, it is something that is feasible, and as we push the limits in interventional cardiology, we have been able to successfully perform those cases in very elder population, a lady who had very active lifestyle. But as we push our limits, age should not be a factor that would hold us back.
Great.
So I'm going to use a Casper stent, which probably in the West comes by the name of Road Saver. This is from Microvention Turomo. And this is a double mesh layer stent. So it's got this is 825, which means it's 8 millimeters in diameter. So we usually we size according to the size of the common carotid artery. And the double mesh layer is 25 centimeters long, millimeters long. And this is a self-expanding stent. So important thing here is, which I'm going to demonstrate just now, that if you see the first marker, okay, so, yeah, zoom on that, please. Can we zoom? So the stent does not start from the distalmost marker that you see. After the distalmost marker, there is a gap. There is nothing in between. This is just the delivery system marker. And then there is going to be a single dot, which is where the anchoring system or the open cell design starts. And then there are going to be 3 dots. That's where the double mesh layer starts. And that's where you need to be careful, because you need to cover the plaque with the double mesh layer. Okay, okay, it's open. All right, fine, thank you.
The way it works
Okay,
is that...
so remove the DSA, please. Remove the Rota. Okay, and go higher mat so that I can show the dots to them. Go higher mat, yeah, go higher mat. Okay, center please. Center please. The other way, the other way, the other way, the other way please. The other way, okay, that's it. So let's do
the
it.
Casper has a double layer and inner mesh is very thin. That prevents the protrusion of the tissue, and theoretically it reduces the chance of embolization. How long is the stent, Dr. Asim?
This is a 25 millimeter stent. And the good thing, other good thing is that this is resheathable up to 50%. So after deployment of 50%, okay, let's take a test here, please. Test. Okay, so looks like a good position here. So I'm going to deploy it fully now. Store fluoro, please. Okay. All right. Store fluoro. So what we need to make sure is that our plaque is fully covered by the double mesh layer. That is very important, so you need to be very careful with the markers of the stent.
It's a self-expanding stent, so when you pull the sheath back, it just opens up. And you tend to put that double mesh portion across the stenosis.
Yeah. Okay. Pull the system, please.
If you jail the side branch with the external carotid, it doesn't really matter. There's enough collaterals in the face to supply everything. And we can see the pouch is there. It's got the contrast in it. So maybe this plaque shift will occlude that pouch altogether, and that should be really wonderful.
Yeah, so we've got an excellent result here. Don't need to post-dilate, do anything to this stent. The pouch is now outside the double mesh layer, so the patient is safe from that. And I'm going to retrieve my filter now. We can see that the whole system is going up. There is no flow-like situation, so the filter is not choked, and we can easily remove the filter for now. So
there's no post-dilatation planned here.
No post-dilatation, so this is adequate result. That's why I did pre-dilatation with a 5-way balloon. Don't need to post-dilate at all, and I want to avoid the cheese cutting effect. So
that's really excellent, you know. And self-expanding stents have this tendency of getting to the original size with time. So they will grow. And I think it's an excellent strategy to have a larger balloon for dilatation and then trying not to post-dilate. Yeah. Would the panelists want to say something, Tahir and Bilal, and would
yeah,
you...
this Sohail, Naeem here, Naeem Tariq from Oklahoma City. Sorry, this is late at night, and I'm in my car, so I don't have my picture on, but a great case. And I think I had not utilized aggressively pre-dilatation, and got a great result. So maybe I will try this. I haven't really looked into the latest papers suggesting that certainly this is a food for thought. And again,
Okay, let's take
as you
cerebral
know,
circulation.
you can mention it for your fellows that we also have tapered stents where it could be a smaller size for the internal carotid and a bigger size for the common carotid. So like a
This is a
710 or
tapered
an
stent,
810,
Bilal.
where the common carotid size is 10 and the internal carotid size is like 7 or 8 millimeter. You can use that. There are different types and sizes of the stents available, which size the difference in the branch, difference in the carotid size a little bit better.
All right, center, that's it. Show me the lateral view, please. So, General Sir, what we do is before doing the procedure, we always take a pre-procedure cerebrogram, and then at the end of the procedure, we always compare it. So I'm going to do a post-procedure cerebral angio now. Okay, ready for DSA?
Looks like a very good result. Asim, extremely slick procedure.
Inject, please. Okay, so we can see that AC, MC, everything is fully patent. Let's go back to carotid view, last view for them. Come back to the carotid view, please.
It's very important to take pictures pre and post of the intracerebral arteries, especially the Towns view, and work out all the vessels are there. You can count them. Some people ask the patient to hold a squeegee ball in the hand to keep, so they keep squeezing it so you know if there's any, although I don't think it's really useful, but some people want to do it more for live shows just to, it is done in initial cases.
What are the dangers of post-dilatation? They don't do post-dilatation in carotids?
It is a very optimal result, and you need about 20-30% behind. If you do 1-to-1, you can perforate. And this is self-expanding. It will grow to its original full size with time. And the aim is not to totally get rid of the stenosis, it's to stop the embolization. So it's got to smooth it out, block out that little pouch, and that's the aim. The aim is to prevent
because they have got the filter device
it's an excellent result, and that little pinch at the external carotid is totally insignificant. It doesn't really matter.
That's okay. You have your time? Bas theek hai. So, just we've done a quick neurological exam. Patient is perfectly fine, no neurological deficit. We've got an excellent angiographic result. So I think we are done, and I'll welcome any questions that anybody has.
Right. Any comments?
Excellent results here from Orlando. The question is, what is your strategy for anticoagulation post-carotid stenting in this particular case, with most of our peripheral cases going towards antiplatelet plus anticoagulation, say low-dose rivaroxaban in leg cases, for example, and in the coronaries, do you have any thoughts on combining antiplatelets and other anticoagulant class of drugs going forward with carotids? Yeah, so as per the current guideline, it's only antiplatelets. We don't have anticoagulation on board. So it's the bare metal stent policy as of coronaries. So 1 month dual antiplatelets, and then we move on to single antiplatelet lifelong. But there's no anticoagulation unless patient has some compelling indication for anticoagulation. But for carotid stent otherwise, no, it's only antiplatelets.
So we've only given 5,000 heparin just to prevent any clot in the equipment, not like angioplasty where you just push the ACT higher up.
I would like to ask one question
Yes, please.
from Dr. Asim and yourself. That these stents are bare metal stents, are they?
Yes.
And why they are not using DES?
It's such a large lumen catheter that the small incidence of ISR is almost negligible in these stents. It's such a large vessel. There's no ISR in these vessels.
Well, the rule of 3.5 was always there. When the vessel was more than 3.5, we used to do bare metal stenting in old era, even in coronaries.
Sure. ISR is, see, a proximal LED, Austral RCA, certain other places are more notorious for ISR. So this is very little ISR here.
Same rule which we used to follow in early 2000s, that if a coronary artery is more than 3.5 or 3.5, even a bare metal stent would do.
Asim, excellent result. Just a quick question. What is your decision based on sending the patient for surgery versus bringing him or her to the cath lab for stenting in this kind of cases?
So, Dr. young patient and concentric calcification, I think these are two areas where I would any time prefer to send the patient for surgery. Rest, everybody comes for stenting.
If I may add to that, there's sometimes a thing known as hostile neck. You know, if you got radiation done, previous surgery, very short neck, higher bifurcations, those are things which a surgeon cannot get to. And by and large, there are trials of surgery versus endarterectomy, and the two seem to be very comparable now.
Yeah.
And but the tendency is to keep them medical-like with coronaries, because the incidence of stroke with the current data is about 3%.
Yeah.
And the guidelines are now suggesting that unless you can get the incidence of stroke in asymptomatic patients to less than 2%, it will not be class 1 indication.
Tahir, what do you do like patients who have a severe triple vessel and going for cabbage and they have a severe carotid stenosis also? I just wanted to get an opinion from Dr. Tahir. Are you there?
Sorry, I'm interrupting. Sorry for interrupting, but the other lab has been waiting for quite some time and they have their web in position, I think, for the last 20-25 minutes. So they are really eager for you to switch to that lab now. So if you could kindly switch to that lab, they really have been waiting for a long time now.
Quick answer, go with the symptomatic issue first.
So one question. Self-expanding stent, I think they're all bare metal. I don't think they have drug-eluting in self-expanding.
Yeah.
One question here, if you please allow.
So we could not really work out the strategy people are having for carotid stenosis along with the three-vessel disease, left man. How do you deal with that in US?
So Sohail and Bashir, so I just like you guys don't have an answer, we don't either have an answer. I think it depends on your surgeon and your cardiologist. So there are surgeons who are going to insist on not operating on a plavix. So if you put a carotid stent in before, then the cabbage would be delayed. Obviously, you can do a combined carotid and cabbage. And then the last is to do the cabbage before and come do a carotid stent afterwards. But honestly, there's no one real answer. Now, if you have a 99% or 95% carotid sitting, then obviously you'll go for that first. And on the other hand, if you've got a 95% bifurcation left main sitting there, then the answer is quite obvious. So I think it's just case by case. There's no specific one approach that's better than the other in this scenario from my standpoint.
If you have critical disease in both, what
you know, so data suggests that if you do a stenting, there's high incidence of stroke. If you do an endarterectomy, there's high incidence of an MI. And the same which applies to coronaries. And what we would do in FIC is if it was acute syndrome, we'd put the stent in, leave the sheaths in, and keep them heparin, no antiplatelets, and send him over for bypass and give him antiplatelets afterwards. And if he's stable, we do a stenting and get him off the table, give him 1 month to endothelize, and then do a surgery. But the combination of endarterectomy and bypass has a very high incidence of death. So that probably is not very trendy nowadays.
Dr. Tahir Hussain, what is your...
Yeah, so in our institution, the vascular surgeons, cardiologists, and cardiothoracic surgeons have sort of looked at this. In our institution, we typically go with whatever is symptomatic first. And most of the results have been promising by dealing with whatever is symptomatic in the first place. Our vascular surgeons are also very comfortable operating on plavix. Cardiothoracic surgeons are getting a little bit more, I think, bold and managing some cases if needed, if absolutely necessary on plavix.
Great. So I think they're ready the next lab for us.
So
let's go over to Tanveer Rab and Dr. Abdul Salam in RIC. Welcome, Dr. Rab and Dr. Abdul Salam. Great to see you. What's happening?
Welcome, sir. I'm Dr. Vikas Mazur from Cath Lab A from the RIC Royal Institute of Cardiology. Are you getting me, sir?
We can see a very good picture, but we cannot hear you well. You would have to speak a little slow for us because the voice tends to break up as it comes across.
So, now.
Yeah.
Hello? We need to get the audio on. Can you hear me now? No.
We can hear you and see you very well.
Okay. So, hello, Sarkun, and thank you for the invitation, Bashir, and RIC, and our good colleague here, Dr. Abdul Salam, and his fellows, to this interesting case. We've been waiting for a while to do this. So I'll let one of the fellows present the case, and we'll go on with the case then. Thank you.
He's a 70 gentleman
hypertensive, non-patient of COPD, presented to us with angina class 3. His echo is normal, ejection fraction of 60%, his labs are normal, he was subjected to transradial angiogram. His angiogram revealed a triple vessel coronary artery disease, and we advised him CABG because the syntax was more than 30. But CABG was turned down by the surgical team due to advanced age and comorbidities. So we brought him here after discussion in the RT meeting, we brought him here for the PCI. So this is the RCA, and RCA is the calcific banded tortuous vessel. And we wire the RCA, and then we extend the wire with Rota wire, and now we want to do the Rota of this place. So a few things about this patient, as you know, we're discussing revascularization guidelines. With stable ischemic heart disease, whether you do CABG or PCI, there's really not much advantage in multivessel disease. But now this patient has unstable symptoms. CABG is better, but he's got normal LV function. So if he had decreased LV function, if he's a diabetic, CABG would definitely be the way to go. But if he has normal LV function, he's not a diabetic, so I think the data is about equitable. So he's got a heavily calcified vessel, but of interest and of interest of time, the idea was to show you this tortuous, bendy, calcified right coronary and how to approach it. So what we've done, what Abdul Salam has done is put initial workhorse wire and swapped it out over a microcatheter with a floppy wire. We will do something different. This is going to be done all transradially. We do not put in, at least in the States, we do not put a temporary pacemaker in. So we don't give a Norflin before starting with a rotablator burr. So if you have questions, please go ahead and ask now. Otherwise, we'll go ahead and start the case.
Yeah, Tanveer, sorry, so I missed, what was the left system like?
The left system had mild distal left main disease. The calcific lesion is in the second marginal vessel. There's a long lesion in the mid LAD.
So let's get the opinion from our panelist, Dr. Bilal. What would you do?
If you could see the left system also, maybe that would help.
Yeah, I think it would be helpful to see the left system if you're able to show that. Because I think it all depends on the technical feasibility of it. If the patient is not interested in surgery and the LAD is technically feasible to do, I think it's very reasonable. But if it's a technically very hard procedure to do, it's okay to reinforce the need for an operation.
I think we bring the friends up, but my opinion was with multivessel disease, we stage the right, which is the more complex lesion, and then do the LAD next and just see how we do the medical therapy before we work on the circumflex. So do a stage procedure, it won't be all in one go, but we'll try to get your friends now.
I think, this from a atherectomy perspective, obviously there is tortuosity here. There's a moderately long lesion. There are two segments that are beyond one bend. I generally tend to try and, avoid going around bends with a rotablator, but try and either manually advance it or use a dynaglide to go around the bend and then try to use the high-speed atherectomy in the straighter segment. And I generally tend to keep short movements in my burr so that I'm not exceeding, getting my burr out of control. Because that's when you get into trouble, you get too aggressive. And then once I treat the first lesion, then I would just gently take it around the bend and then come to the second lesion before I would start treating it, not try to run through the entire M-shaped tortuosity with one run. I think that's where we get into trouble with dissections and distal embolization.
So what kind of speed you are going to use?
So I like to use 160 RPMs. I go very slow. I do use a 1.5 burr, the standard burr for my cases, and I go very slow. I still burr. I don't dynaglide. If I have trouble pushing it, then I'll dynaglide it. Otherwise, I'll generally go very slowly around the curve and stop very frequently, for several seconds. I know what the pressure is like, etc., before I proceed. The important thing also to know is that if you go through and if you have trouble coming back, you might have a stuck burr. So you've got to be very careful how you affect the lesion going forward and backward in this case.
So what speed do you use? Tanveer, what is your speed?
160 RPM.
Is that so everyone does? Tahir Hussain?
Well, actually, I would probably avoid the rotablator in this case. We do have access to orbital atherectomy with glide assist, which was very nice. You can go at 5,000 RPMs around that first bend, and then you can actually start doing orbital atherectomy on the way out. And then lately, I've really enjoyed using the shockwave technology. I'm not sure if you guys have that in Pakistan yet, but that lithotripsy concept really works very well. I think you really only have to spin on that more proximal lesion. So I really had to take care of somebody's instant thrombosis on a graft master because they did a rotablator case and on the bend, they perforate it. So I stick with orbital atherectomy or shockwave.
I think once the shock waves come up, personally, haven't done any orbital atherectomies at all, to be honest with you. And I think the role of orbital atherectomy, I'm not sure will be out there or not, but I think certainly shock wave is going to change the market, the way we do things. Can you all see the film?
Naeem Tahir here. So, that's the great part of interventional cardiology. It's all about your experience and everything else. So, actually, this is the one
Let's go to films. There's mild distal left main. You can see there's a lesion in the marginal, which is a long lesion, and there's a longish lesion in the LAD. That's calcified. And you can see the LAD lesions, multiple plaques, ugly lesion, multiple stenosis. It will have to be treated. It might require another atherectomy procedure, but certainly not at this setting.
Do you guys think about doing a hybrid procedure, Lima to the LAD and then potentially a PCI to the right?
I mean, this is a surgical turndown. I mean, if you add robotic capabilities here, Lima to LAD would be a great choice, I think. But I think he needs multi-vessel therapy, and I think at his age of 82, with surgical turndown, COPD, fix the right in the LAD and see how he does.
Okay,
Reasonable?
that sounds great.
I agree. And I was going to point out earlier, Sohail, that we have personal experiences. I would be a lot more comfortable just rotablating this as opposed to orbital atherectomy. So I use a lot of orbital atherectomy. I'm one of the Eclipse trial PIs, but I also use a lot of rotablator too. And I found that I have more perforations with orbital atherectomy than I have with rotablators.
Okay, great, Naeem. That was a great comment.
So I'm really an offline before I start treating. I'm just going to just burp this burr for just a second. Okay. Now I'm going to go now, real slowly.
So we're going to give short burrs and not go too deep. Because if you do that, you tend to get more distal embolization. And
pressure came back up. We'll go again now.
Dr. Naeem Tahir, what is your routine average speed you use during Rota cases, or it varies from patient to patient and anatomy?
Normally, I will go with 150, 160, what Tanveer is doing. The case that we did yesterday that I was showing you afterwards, at 150, 160, I couldn't cross the stent. So while we were spinning it, we pulled back into the guide and went up to 190 to cross that stent and further distally. But 150, 160 is the way to go. I think there's two things. One of the things is if you go really fast, sometimes you can squeeze through, but then coming out, you're going to be stuck. So it's better to go slower and steady, and so that you don't get stuck.
The wire tends to come back a little. Maybe if we push it further down, it'll be safer for the patient.
To be honest with you, even before we started, okay. Let's pop a little. Wait a second. Go ahead.
Tanveer, are you happy with the position of the wire, or does it need to go further down?
I don't think I can push the wire too much. I've tried, okay? Let me do this. Let me see if the top lesion is fine, okay, now. I mean, there's a little thrombus in the middle, I think, or it could be a fractured plaque. I'm not sure I'll be able to go back to the bend because the rotor might get trapped in the wire, so I'll try to push it if I can. I
think that you could go a little further with your rotablator, and either on Dynaglide or while you're doing the rotablator, you could probably be able to push that wire further, and at that time somewhere in the middle.
Okay, sure.
Yeah, that's exactly right. I think if you push the rotor wire forward without the Dynaglide on, the system tends to get pushed back. You have to get rid of the friction in the system to be able to move the wire forward.
No. The guide is too far back. You've got to re-engage the guide.
You see, one must never move the rotor on the black portion of the wire. And that'll just snip it off and we'll have a perforation.
No, we'll have to put the wire out a little bit more. So push me to the diagonal and see if that works. Okay, so say, chalo. Yeah.
And the brake will have to be defeated. The black knob will have to be pushed inside to defeat the brake on Dynaglide to move the wire forward.
Yeah, that's what I was going to ask, Bilal, any tips and tricks, but sometimes it becomes very difficult to push the wires, especially this kind of anatomy.
Yeah, so
The only way to do that, Bashir, is that you have to have the black knob which locks the brake in. You've got to press that and then go on Dynaglide and advance the wire forward. Otherwise, the wire will kink.
So what I'm
so
going to do
which rotablader are you using? Are you using the legacy old one or with the foot pedal, or are you just using the hand one?
It's not the Road Pro. So what I'm going to do now, we're going to swap out, we're going to take the rotablader out, and swap the wire from microcatheter, put in more supportive wire. I think distal lesion might eat to the balloon. Lesions in the right are generally very proximal, more than distal. And do the balloon test and see how we do, okay?
Sohail sir, can I make a comment?
So,
if we take
if I was there,
in such an artery, if we take guide extension like guide liner down to the distal lesion, do it first with the rota and then pull the guide extension back and do the proximal lesion.
We swap the wire, remember?
If you can take their opinion.
Or one can take the rotor off, put a micro again, and push the wire down, and then exchange again. That will help.
Because that will be make the life a bit easy if you use the guide extension in such a lesion.
In Rota, you normally try to do proximal and then go distal. Because on the way back, many times it gets stuck because you haven't done the atherectomy. So I think it's better that you do packing movement, go all the way down to distal, and then come back.
But if you are using, you keep the...
May we have a microcatheter? Yeah. Now we are having a caravel microcatheter.
And then pull the guide extension back and do the proximal lesion.
Prepare the bed and the proximal vessel.
The proximal looks good now.
Oh, nice.
Tanbir, is it worth taking the burr out, putting a micro in, reposition the wire, and then go back to the burr again?
Let's see it. Let's see the balloon test, okay? If it is with the balloon, you may not have to go back, okay?
Okay.
I think the distal lesion probably will be amenable to balloon without rota. The distal lesion looks more, less calcified, I mean.
Where are we? Where? Where? Hold the wire.
The lithotripsy.
So you are going to take this monorail balloon or over the wire balloon?
So no, we're going to swap out to a short wire, and we're taking a microcatheter right now to do the swap. Keep coming. Push the wire out. Push it out.
थोड़ा और आगे.
By the way, if you're taking out your burr, one of the nicest, safer ways to do it is to use the magic glide technique. And you can actually glide it out just like you would for orbital atherectomy without having to hold the wire in place.
BMW wire, may we have a...
Sorry, Bilal, didn't understand. Can you say it again?
Yeah, so when you're exchanging if you've done your rotational atherectomy in these tortuous lesions, the wire is difficult to exchange over and it moves a lot. So there's a technique called the magic glide technique where if you go on Dynaglide and you put your white clip inside the brake, okay, then when you come on Dynaglide, you can actually pull the advancer backwards, take the burr out, and the wire will not move. Because again, it will just simply glide over the wire in a Dynaglide status. And you won't have to have your assistant manipulate the long wire because that's where it tends to move so much.
So we're swapping a short wire over the caravel, and then we'll use a trapping balloon to take the caravel out, and then we'll put a guide liner in to give us support.
रोटा वायर है लेकिन I don't know नहीं आप शायद change कर दे. They might have changed it. वो Corsair आया ना. So it's a normal wire now, Tanveer. It's not the Rota wire anymore.
No, we're out with the Rota wire.
Okay.
This is the BMW now.
इसका वो लगा दो.
Exchange.
I'm wondering if, given the tortuosity of this vessel and the sort of it's a non-compliant vessel, if a stiffer wire, perhaps like a wiggle, would have been helpful and made you struggle less, because I think the BMW may give you a hard time with delivery. Maybe you'll get lucky.
That's good enough.
I agree 100% with the wiggle wire. The other thing I was going to just mention as an aside is there's two different types of Rota wires that we have. One is in the extra support, and the other one is the floppy wire. And so when you have such a tortuous artery, way back when we started initially rotablators back in mid-90s, our strategy was that we would actually put a stiffer wire at the point to straighten the tortuosity out. Turns out that if you do that, you actually have more perforation. So you actually want to use the rota floppy wire when you have a fair bit of tortuosity.
2.5 balloon, 2.5 balloon, sir,
No, well said, because that causes so much of wire bias that I think you tend to ablate more on one side differentially, and that's where you have more extensive dissections by putting in stiff wires.
Just put the guidelines through, please. अंत तक लाइए ना उसको. मुझे balloon दीजिए फिर. So you've got a guideliner for support, okay? For tortuous vessels, I always do that.
So what are you doing now, Tanveer?
We put the guideliner in, and now we're going to go with the balloon to dilate these areas, okay?
So you would need a guide liner to push the balloon down, or
I think in a curve, you may have difficulty pushing the stent, okay? That's the reason I'm doing that.
Mm-hmm. Yes, please.
What, distally first? Push the guideliner in.
So by balloon tracking, you mean you push the balloon down, you inflate it, and then you ride the guide liner down. Yeah. It's just that when you, it's a very if it's a calcific lesion, you want a guide liner down so that when the stent goes down, it doesn't get abraded and the drug doesn't get wiped off. So the calcium will always catch onto your struts and not allowed to go down.
I think the technique half balloon
out
so
of the many people, what they do is they put the guide liner in, then they put a balloon in and take a balloon distally, and they use it as an anchor. And then they push the guide liner down, and then they deflate the balloon, take it out, and run the catheter through the stent through this guide liner and take it there.
No, so I'm not talking about anchoring.
Yeah.
I'm talking about your balloon, half of the balloon outside the tip
on
of
the
guide,
tip, yeah.
outside the tip, low pressure inflation. Then you take it forward. Because sometimes it's a calcified lesion, guide liner can cause problems. Okay, so and then because the balloon, half inflated balloon is out first, which is a lot softer, and you take the like we use in radial if it's difficult.
Right, like the sheethless entry we use.
Yes, so we use in guide liner many
So
times.
there are different techniques of getting the guide liner in. One is to use a tracking balloon, other is to have a half inflated, half sticking out balloon at the tip of the guide liner.
You don't have any weight, that's a good thing, right?
So it looks like you decided to just balloon it now and not go for rota anymore. It looks,
no waste.
With the guide liner, you are able to get the balloon down.
We are able to do that. Come back more. Inflate kar idhar bhi.
What size balloon do you have?
2.5. But I was next to south. Okay?
So it went down easily?
Yes, with the guide liner. Now bend per kar next. Okay? Guide liner piche kare thoda sa, wide thoda piche kare.
I think, some really good comments have been made about the guide liner. I think whatever technique you use, whether it's half inflated balloon or just advancing it over an uninflated balloon, the important thing is not to advance the guide liner through a calcified artery without a balloon leading it forward. I think that's a mistake. You know, you'll get away with it a few times, but inevitably it's going to cause a dissection and a serious one.
Doesn't matter, push it down.
And I would like
That's a
to
great
echo
tip,
that
Bilal.
again. So if you don't use the
So
guideliner,
invariably we
Do I was
should
next,
not
okay?
take it in a
assist the
corneal
guideline and
without
going
a
down.
balloon in front of it.
We always
100%
talk
of
of
the
putting the
time.
guideliner down, but it will cause dissection, and one has to do every time the safest possible method. It'll save us a lot of issues later.
So use the balloon in front of a guideliner every single time. And the other technique that was being mentioned, it's called inchworming. So you take half of the balloon out, semi-inflated, and just use that to go forward. The last thing I would tell you is once you take the balloon out and you are injecting through the guideliner, please make sure that if you're using an assist device that you decrease the PSIs and also the amount of the volume of the contrast that you're using, or even the hand injections will be very soft. You can get a lot of dissection and perforation if you push hard when you've got a guideliner deep in there.
That's a very great point, that when you inject, some people want to see what's beyond the guideliner. So if you inject, it has to be just a little trickle rather than pushing it through, otherwise you'll have a huge dissection. We've seen it with
So we're going to start IVUS now.
Also.
IVUS, audience go.
Just a quick question. Are we going to image this to know that what we have done so far, what is about our calcium? Did we have an adequate modification of the calcium? And another thing to Dr. Najeeb is that whenever there is like in this anatomy, we have to trick it with the balloon, the guideliner, because if we do it without balloon, we are going to dissect. So in this anatomy, but if a straightforward whistle of 4 or 3.5, then we can track the guideliner without the balloon.
Next, you just adding
Imaging,
to this.
no, they have the ultrasound. Can you show us the ultrasound on the bigger screen, please?
Yeah, they're doing an IVUS. Can you show the IVUS on big screen, please?
Doesn't matter. It was Go down the curve a little bit. Not push it. We have to use the guideline to help see the guy. The volcano tip is very bulky, so okay, it's not going to make a move. Okay, so to record that, we'll know at least what size the vessel is. So 1, 2, 3, 3.5. Bring down the collar, please. Bring down the collar. Nearer?
Guide will have.
Let's do.
So meanwhile, sir, one thing from the panelist. I just want to ask if there is problem still. You have just passing the balloon over the guideliner, and balloon is not going down because of severe calcification and porosity. So what kind of other way out we can just keep here? Either the smaller balloon or without balloon we can go out.
Also, the volcano tip is very bulky, even this one, okay? So it doesn't make bends very easily.
Okay, guys, in the interest of time, we'll try and squeeze in a talk from Bilal Murad, and please carry on in RIC. We'll be back with you in a little while. And in the meantime, Bilal, if you have your talk ready, the Rota burr becomes a friend or a foe.
Sorry,
if I can give a 15-second response to the question that was asked. If your balloon doesn't cross and your guideliner is down there, you can actually use rotational atherectomy through the guideliner as well. You just have to be aware of the size limitations. Quickly go over to mine.
Of course, you're at that point, you're going to have to be able to get a micro catheter and change out for rota floppy wire.
Larger balloon
unless you already have it.
3.5 long balloon there.
All right. Can you see my slides?
Not yet. I'm sure they'll be on very shortly.
Thank you, Dr. Bilal Murad, for answering. Thank you very much.
Can't go beyond that, okay?
So are you able to see my slide here?
Not yet. For those of you who do not know, we can see them now. For those of you who do not know Dr. Bilal Murad, he's an amazing guy from Chicago. He's come and proctored many of us, and we've gained so much from him.
balloon, not regular compliant balloon.
Bilal, the boss here says you got 6 minutes to do your talk.
I do. Thank you so much. Assalamu alaikum, everybody. It's lovely to be here. I'm really sorry I'm not there in person, inshallah, next year. So I am going to quickly talk about the how to manage some complications of rotational atherectomy. I think all of us really need to understand that the very first intervention that we do is the most important intervention that a patient is going to have, because all future procedures that that patient may require at that particular lesion will depend on what we do. So therefore, using appropriate imaging in calcified lesions to identify the pathology, how much calcium there is, and I know that Sohail has already talked about that, whether it's deep, nodular, or superficial, and using the appropriate technology.
Excuse me, Bilal, can you go on slideshow?
Oh, sorry. I thought I was. Okay. All right. How about that? Can you see it now?
Yes, now it is. Yeah.
Okay. So using the appropriate technology to identify what kind of calcium we have and then appropriately treating that really is essential. And that makes all atherectomy tools, particularly in Pakistan, rotational atherectomy, it really is indispensable tool in any lab that performs complex PCI cases. I really have a hard time imagining my own career sort of being without rotational atherectomy in my hand. However, everything comes at a price, because this is essentially a potential weapon. You need to understand what the limitations are, when can you use it, how to use it, and therefore it appropriately so demands us as an operator to demonstrate a commitment towards excellence, understanding the device, how it works, appropriate case selection, appropriate planning, and being very patient, very deliberate about how we actually approach atherectomy cases. Now, we're all familiar with a lot of complications, and one of the acute complications, obviously, of any intervention, complex PCI, is equipment loss or entrapment. And that can happen with rotational atherectomy too, and that can result in vessel thrombosis. It can result in perforation, resulting in tamponade as well. So amongst several of the complications of atherectomy is, of course, burr entrapment, which is defined as the inability to retrieve a burr which is now locked inside a lesion, and therefore it can result in serious, potentially fatal complications. And it's important for us as operators to be aware of what are the potential techniques that we can use, and if they are unsuccessful, to refer the patient for emergency cardiac surgery. And therefore our lab and our personnel, we should all be prepared to deal with those potential consequences. Now, a little bit about the atherectomy device, rotablator. Now, as you all probably know, the distal half of it is the one where the diamond is essentially on the burr itself. The back end of it is all polished. The burr has a sheath. It's called the flushing sheath, and that's a 4.3 French outer diameter. And the burr sizes, you're all aware of that, 1.25 to up to 2.5. In the 6 French system, through the transradial approach, you can only go up to a maximum 1.75 millimeter burr. The issue with the 1.25 millimeter burr is that the flushing sheath is slightly larger than the lumen that the actual burr creates. That is not the case with the 1.5 and larger burrs. Therefore, interestingly enough, the burr entrapment happens more with a 1.25 millimeter burr than it happened to the larger ones. That's not to say you should jump onto a large burr right away, but that is one of the things you have to be careful about, because the ablation surface area with the 125 burr is significantly smaller, and therefore at high speed it can actually watermelon speed, like skid right through the lesion, but then the sheath actually can get trapped. So why does it get stuck? There's something called the Kokeshi phenomenon, where a Japanese doll demonstrates that the head is actually larger than the body. And that's what happens with the 125 burr, is that the flushing sheath is large. So what are the factors that lead to it? There are anatomical factors like vessel tortuosities, particularly if there's a recent stent. Coronary spasm can do it too. But really it's mostly a technical issue. How aggressive are we with advancing the burr? And realizing that a small 125 burr advanced too quickly can penetrate a lesion without adequately ablating the whole segment of disease. And of course, thirdly, advancing a burr during deceleration is also a potential recipe for a complication. So this is an example, for instance, of a patient that I did. Unfortunately, I have not had many cases with a burr, but this is a very similar anatomy to what was just being demonstrated here. And I was able to take a 125 burr all the way down, but except for this particular lesion. So I treated that with orbital atherectomy. But then for the other ones, I went to, I'm sorry, I should have been a second one here. So, but this is my technique of generally doing it, is that I generally tend to peck at the lesion very gently in short bursts. So just to kind of, how do I plan my procedure? I assess the anatomy, I understand what is the patient's clinical risk tolerance, Am I prepared to deal with a complication such as perforation or a burr getting stuck? And then look at the burr size, look at the wire bias it's going to cause, and then ask yourself this question: am I ready to deal with this? Now, how do I try to minimize my complications? So avoid starting with a large burr. Confirming, of course, the rotor flush is on, so your burr doesn't decelerate. Making sure the wire clip is always in the back end of it. Activate the burr proximal to the lesion. And I tend to move in short segments. I generally do not go more than 5 to 8 millimeters at one time. I like to peck at the lesion like a woodpecker because I'm not going to force my way in. I literally want that plaque to be ablated and create a smooth channel towards it. Avoid deceleration. Do not push. Let the burr glide. And then don't go for very long, less than 20-second runs, not allowing it to decelerate. And sometimes it's okay to downsize your burr and go to a smaller one. So if the burr entrapment does occur, the first question is, are you able to rotate the burr using a dynaglide? And if you're able to do it, that's great. You can do that. You can apply some gentle traction. But if you're not able to do that, then there's this whole algorithm which my friend and colleague, Dr. Manos Berlakis, has published in the Manual of Percutaneous Coronary Intervention. And kind of go gently a little bit through this in the next few slides over here. So remember that when you apply traction, the guide is going to dive forward. So disengage the guide if you have a disease of a proximal vessel, otherwise you can cause a dissection. Don't pull too hard because the artery is going to move when you take that burr and you pull too hard at it, and that can cause serious complications as well. The first step, of course, in a sixth is to think about, can I deliver a wire beyond the burr and dilate that area and free up my burr? Well, in a 6-French system, even in 7 French, there's not enough room for you to do that. So if you're planning on doing that strategy, you have to pause, make sure you anticoagulate appropriately, get another access and put another 6 French guide in, and try and cross that lesion and use small size balloon and gradually upsize it until you can dilate that segment where the burr is stuck, free it up by modifying the plaque. Of course, the risk is you can cause extensive coronary dissection in doing so. But so these are some of the anchoring techniques. The other one is you can use a 5 French guiding catheter. Or you can use a guide liner, for instance, to do it as well. But for that, you have to cut the burr. You can also deep intubate a guide catheter. And actually, our friend Sohail Khan has published on this and was kind enough to share his experience with me as well. That this is an image from his paper where he shows that when the burr got stuck, a 1.25 millimeter burr, he simply pushed the guide all the way into the vessel. Again, he was able to successfully apply gentle traction, pull it back, but recognizing that it may not be possible in diffusely diseased or tortuous vessels and can cause extensive dissection as well. And then, of course, there are some other strategies like how do you disassemble a rotoblader. So if you are not able to do gentle traction, take it out, then it's time to actually cut the rotoblader. And you can do that by just going a little bit forward beyond the advancer and cut it. When you cut it, that flushing plastic sheet that I showed you earlier will essentially peel off. Now you have a peeled off sheet, you have a cut rotoblader shaft. You can advance over that anything you would like. You can actually advance an 8 French guide system from the transfemoral approach, or maybe just take a sheetless 8 French guide through the radial approach, because now your burr is fixed, so you can actually advance your brand new sheet right over that. Or you can advance a guide liner as well over that as a first step instead of changing the entire sheet. But again, the idea being that you're trying to get something so close to the head of the burr that it will allow you to cross a wire and a balloon and give you some more traction perhaps, and then you can pull it out. Of course, if that doesn't work as well, the next option is you can also use a gooseneck snare. Move your shaft right up to the burr head, apply the gooseneck, grab hold of the burr head, and see if you can sort of apply traction and pull it backwards. So this is again summarizes for you what I was just mentioning here about how to deal with it using between manual traction, using different guide catheters, second access, snaring it, balloon angioplasty it, cut the guide liner, the shaft, and then exchanging it for a larger guide catheter. Of course, if none of this stuff works, you're left with no other option but to use surgery. This is just some pictorial examples of how you can manage that. You can cut the rotoblader. As you can see here, this is just in front of the advancer. Peel off the sheath backwards. And then, now that you have a cut advancer here, you can apply your guide extension. which is here. You can see the operator putting the guide extension over the rotor wire or the shaft itself, advancing it over the broken shaft, and then coming close enough to the head of the burr, and then pulling this trapped burr and into the guide liner, and then moving the whole system forward. So this is one of the things that can happen if you are not careful. This is an example of a patient that I found on case review, a densely calcified LED lesion. The second image here demonstrates to you that the operator is really applying too much pressure. It's not a pecking movement. Look what happened initially. He's stuck here now. He keeps applying force. He's pushing his way rather than pecking his way out. He finally gets through it and gets this false impression that I'm actually through it. But then look what happens in this next third run. It comes forward, it's getting stuck again, and then look where it goes. It goes right parallel, or completely out of the plane of the wire, right about there. And what's happened in the second run is where all the damage occurred. By pushing too hard forward, he probably dissected the artery, had a lot of eccentric ablation, and then when he pushed again too hard, it went right through the wall of the artery. And you can see here there's a massive perforation here that you now have to deal with. So it's all about procedural planning and techniques. This is kind of a really strange, I want to demonstrate this not as something that I would recommend doing, but I would probably try and avoid doing something like this. But this was a case that I found in the literature of a case where the burr actually got stuck. And to the credit, the operators tried everything possible and it didn't work out. So the patient had an extensive dissection by this time with all the manipulation and was getting ischemic. So they actually ended up putting in a stent. Somehow were able to get a stent through a guide liner into the vessel and stented and trapped the burr behind the stent. And what this image is showing you is this is a trapped burr, and this is a second stent being deployed. And then to take the burr out, once the ischemia had been sort of been treated, now that the dissection had been healed, they actually used a gastric biopsy, forced bioptome, through the contralateral guide catheter, grabbed hold of the burr shaft and then pulled out that burr. So not something that I would actually necessarily recommend doing. So in summary, I just want to emphasize that entrapped burr, as we all know, is a very serious, potentially fatal complication. The key really lies in prevention, in preventing it, and the emphasis has to be on planning, and then the technique that we have, and we must be aware of all the equipment that is needed and what are the consequences of the complication of rotational atherectomy, and be prepared to deal with it. So I think my time is probably up, and I'm happy to answer any questions.
Yeah, that was a great case, but it's a real terrifying experience to have a trapped burr. So one must have this algorithm right up there for those who use burrs regularly. Yeah, and now I think we should go back to the live case. So can we go back to RIC, see what we're doing? And thank you, Bilal, for a great talk and very provocative. And I think we need to memorize these steps and these techniques. Can we go back to RIC, please? Hi, Tanveer and Dr. Asad, how are you doing? Please connect the voice back with us.
Sorry. While you're connecting, people need to be careful. You put the guide liner in, but your guide catheter is still there. The ostium and the aorta is calcified. Keep an eye on that guider, that you can still cause a problem with the guider, because the ostium, you see, is a lot of calcium in the aorta. So guide liner, don't look at the guide liner tip only, still keep an eye on the guider. I have seen people causing a problem there.
I think you're so right. I think we see as many complications with the guide catheter and the extension as we see with the balloons and the stents and everything. We tend to think of all those glorious stents and balloons to cause complications, whereas many times it's very basic thing which gets a problem for us.
Also, the
last
quick question. Go ahead.
Okay, so the last 3 times that I've done this, we're a high volume cath lab, and so if anybody gets stuck, they call me. I'm there 5 days a week, 12 hours a day. So what I've found is basically if you cut the rotoblader and take the sheath out, even if you have 6 French or 7 French guide, you can sneak a wire in there. If you can sneak a wire in there, then you have the Rota wire and the actual Rota blader and the new wire, and use both of them and advance your guide liner in there. And then once your guide liner is close to the ostium of the artery, then advance the smallest balloon you can get and make sure you're ahead of the guide liner. And take the guide liner in as much as you can at that point. And then if you can take it as close as you can, this seems to work almost the best for me. So, that's just going to the extreme right off the bat is what I'm ending up doing nowadays. Bilal showed that very, very nicely. But the only point that I wanted to add was that once you take the sleeve off, you can at that point squeeze in a 014 wire through even the 6th French or the 7th French.
The only thing is
both the wire and that
in these very complex cases is in the complex cases, if your hemodynamics allow you, use nitroglycerin to eliminate spasm, and also the telescope is an alternative to the guide liner. It's been a very nice device as well. And the key thing, I think, with all operators, try to get your mother-daughter sheath, further in, as far down as the vessel. Don't be afraid to take it almost 2/3 the way down, so that you don't have to, get the equipment stuck anywhere approximately. So go deep throat on those, and then also you.
But a word of caution.
It goes in, and the sheath and your guide also catheter, you suck it in as much as you can safely, and then you take everything out together and pull it out.
A bit of caution when you're pushing these guide liners and these things in. Make sure that you push in very carefully so you don't bend the shaft. Because the moment you bend the shaft, it's all over. That equipment becomes useless. It won't go any further. So sometimes what I do in these situations is I ask my assistant to hold the wire and I grab the shaft with both hands and move it together. And so once it just produces sustained pressure and it tends not to bend because the push is distributed on a larger area.
Once the burr is struck, what is your strategy of anticoagulation at that time?
The question is, if the burr is stuck, what is
your strategy of anticoagulation? Because
I would have thought the same ACT as any angioplasty.
You keep it around 350 or what?
350 is basically for retrograde PCIs. So anything 300
around 300
is fine.
You will keep it.
Anything 300 is fine.
Because it may take a long time while you are doing the procedure.
I think there's a point here that if the procedure becomes longer, one must check the ACT every half an hour. That's something we tend to forget. So make sure, that's a very valid point, Dr. Harun Babar, that keep an eye on the ACT. And for labs which do very regular long procedures, they must make a protocol of getting an ACT done every half an hour.
Actually, that's an excellent point. In our lab at least, and I suspect in a lot of US labs, our nursing staff remind the operator every 20 to 25 minutes about getting another ACT. And 30 minutes is reasonable as well. But I think somebody should take charge because I think the operators tend to forget. And so what we do is we empower our cath lab staff to remind us, and they're actually very good about that.
Yeah, that's really a very valid point. You must train your staff and empower them for certain decisions.
And also the buddy wire, add a buddy wire after you've treated the vessel, before you put your equipment in, sometimes just add a second wire at that time can also help you deflect off those acute or tortuosity of the vessel. Can be helpful.
I think one thing which we mentioned by all the operators is that you don't push the burr ever. You just do a pecking movement and you grind away rather than push your way through. You drill your way through rather than you push your way through. And I think we need to have these guys numbered, displayed somewhere in the lab. So in case of stuck burr, please contact these numbers, SOS numbers.
That's completely legitimate to do. I'll tell you, as a CTO operator, I have that for several of the CTO guys. And if I'm in trouble, I have reached out to, Simon Walsh and Bill Lombardi, these guys, and people are very receptive to that. So that's actually a very fair comment to make of being able to reach out to people.
I think Bilal and Naeem are on the masters group we have for Pakistan, and we should have Tahir's number there also. And so there should be a bleep there, red alerts. Anybody who's online should.
SOS.
So what I think, asking for a second opinion for some of the smartest people and the best operators is still a good idea, because sometimes you're right in the middle of a raging case, and a simple thing, a junior guy can come in and suggest something, and it's like a light bulb goes off and say, oh, why did not I think about that? So I think the smartest people always turn around and say, hey, what do you think? What other things can I do? Instead of saying I'm the senior most or I'm the most trained person, I don't need to ask anybody else. So that's a great thing that all interventional cardiologists do, and the CTO operators really have mastered that. So everybody is on line with each other and talk to each other and show their cases and discuss this. And I think that is one of the things that interventional community has really mastered and should continue to.
I think that's a very valid point. The moment you get some sort of trouble going, you must call for help because you already had an exhaustive procedure. You tend to get tired, dehydrated, and your mind gets blocked. And so you need to have another hand, another mind there, more so than the mind.
Two is always better than one.
Yes, of course.
They're having a difficult time advancing a stent.
I think they're still struggling with the stent. We've got 2 more talks, so maybe we can get on those talks for a while, and then we come back to RIC because they're going to take some time getting their stent across. So we have Dr. Najeeb here with us. Dr. Najeeb has a very wonderful talk.
Whilst Najeeb is coming up,
wiring an angulated side branch, the reverse wiring technique. So
just whilst Najeeb is going up for his talk, I'm just wondering whether the sensible thing here might be just to stent the proximal segment of the RCA here, because they're clearly struggling to get the stent beyond, and then using the guide liner or guide extension catheter through that stented segment, then to deliver a second stent more distally. I mean, the nice thing about having the guide extension catheter is, of course, that you can stent proximal to distal, so that is one option, because they're clearly struggling in this very tortuous anatomy.
That's a very valid point. I mean, it looked as if after the burr we should just slide the stent in, but it's more like a crowbar sort of a RCA, where the bend with calcium is going to have a problem. So, Dr. Najeeb? Yeah. Yeah, there you are.
Oh, thank you. Assalamu alaikum, and thank you for asking me to share some sort of thoughts about how to wire a difficult side branch. But before all of that, congratulations, Jashn Azadi Mubarak, lots of dua and good wishes for Pakistan, and inshallah, what a great day, 14th of August, and we are here together in Islamabad, actually. My name is Najeeb Azam. I'm a cardiologist in the UK in Stoke University Hospital. We do have lots to do, and I'm sure a lot of you are already a more guru, have done maybe more cases, more complex cases than me, but I thought I'll just share a basic talk. It's a basic talk how to wire a side branch, which is a bit difficult. Can I have my first slide, please? Oh, can I do that? Okay. I mean, initially, before we go to the sort of reverse wiring, we should try different techniques like double, we can double bend, we can use. Is it a pointer will work? Or? You can see there's like a double bend you can use, and then try to make a hinge and then try to do the side, get into the side branch. Sometimes we might have to pre-dilate the lesion, which is distal lesion, because it gives you a little bit of space for maneuvering the wire. Or occasionally, if there's a distal lesion, it's a problem, or keep prolapsing distally in the main vessel, you can just sort of occlude the main vessel by... Oh, okay, thank you. Okay. So, and then obviously that way you can branch, you can get your wire into the side branch. But sometimes all these maneuvers don't work, and there is a reverse wire technique has been described, actually it's described a long time ago. Obviously, especially if it's an angulated side branch, then it becomes quite difficult to wire it. But if it's a significant size branch, side branch, we need to wire it. So some people has described this reverse wire technique. Initially, it was a long time ago, a case was reported. At the time, if you can see that, obviously wire like a hairpin. It's about, first you make a little tip, it's about 4 or 5 millimeters from the tip, and then after that you make like a hairpin about 3 centimeters where the radio opaque part of the wire finishes, and then you advance the wire into the main vessel, then pull it back and try to get into the side branch. But sometimes this technique becomes difficult because the wire maneuverability is not that good once you make a hairpin angle on it. But people has been trying this, was first reported 2008, and then it has been tried. This usually works more in a left main if you have a difficult circumflex to go, but in my experience, if there is a diagonal in mid LED, then it's still, that becomes difficult. And then the next technique was the use of a double lumen catheter. I don't know which one you use in Pakistan. We do have Suzuki and a twin pass both. But obviously there's a cost as well. I have no idea. Do you use both here, Suzuki and twin pass, or? Okay. Okay. So obviously these catheters may need to familiarize. They have the over-the-wire lumen and there is a monorail lumen. Usually if you want to do the side branch access, that wire, you take it over the wire lumen and bring the tip out. I'll show you how to make a curve. First, you make it small deflection, a small curve at the tip. And after that, you need to load your wire from the back end. And then about, again, in 3 centimeter, you make a sharp bend again, like a hairpin. And there are 2 ways. Either you can make a very sharp end, or you can make a slightly rounded end. But this is mostly done through the over-the-wire lumen. Some people has done it even over the monorail lumen as well, but I think it's slightly easier that way. And then you can see, then the wire is bent itself on your double lumen catheter. Once it's bent, then you put into the introducer. And so obviously you'll think about, my wire will get damaged, but obviously they don't. But yes, it does affect. And then you push the wire in the catheter. I don't know if you can see this. That's the example, how you put the wire. You will see the wire is hanging out, and then you push the both things together. Get into the vessel, into the main vessel. You go distal to the side branch, and distal to the side branch, then you need to pull back your double lumen catheter proximally, and then of course after that you pull back the wire, maneuver it a little bit. I think there is a reasonable chance. I'm not saying guaranteed, still people have difficulties, but I think this is maybe reasonable chance you'll be able to get into the side branch. Once you get in the tip into the side branch, then you push the double lumen catheter again. So your double lumen catheter is over where you made the sharp angle. So at least a wire will give you better torque, and then you can torque the wire into the side branch, take it a bit more distally. So, but again, there are 1 or 2 caveats here. If you make a very sharp bend, a very sort of acute angle, it may be easier to cross the distal lesion, but sometimes if you're taking a stent to something over this part, sometimes it becomes difficult because you already had a very acute angle. But if you have a slightly rounded end, taking the device is easier, but if there is a distal lesion, quite tight lesion, then it may be difficult to maneuver your wire distally to the side branch and come back. So these are little tips and tricks need to understand when we are stuck how to wire a side branch, which is proven to be difficult otherwise, but it's important. And all of us will know that we do get stuck. Usually it's better to use a polymer jacketed wire in this one. That's what we tend to do. But again, generally, I usually say, try to use the wire which you are familiar with. Even the polymer jacketed, the wire you use regularly, either, I don't know, which a filter, whichever wire you use, is there's no point trying absolutely a new wire which you have never used, where you already had difficulty in wiring. Okay, that's fine, thank you. I'm happy to take questions, but I'm sure you guys knows it quite well anyway. Your transmission back.
Sohail, one of the new things that I'm sure you guys have seen that is a venture catheter. So that is probably something. Can you guys hear me?
Yes, we can.
Okay, so the venture catheter, I think the dual lumen technique is really good, but it still is pretty cumbersome and complex. So your torqueable venture catheter is a pretty easy, straightforward, where it's an over-the-wire catheter. You take it out and you pull your wire back. You can turn the knob, and it can turn the tip of the catheter up to 120 degrees. And if you pull it back, a lot of times you will fall into the side branch, and then you can access the catheter. But again, we have all of these things, and there are still some side branches you will never be able to get into. But that's another piece of equipment. If you have, it's probably easier than. I really have never had very good luck with the hairpin technique. I've tried it and just given up on it, and just go to the venture catheter anymore.
We used to use venture catheter. We don't use much now because unfortunately, we didn't have huge luck. But number two, that the venture catheter tip, yes, you can move it, maneuver it, but tip is still quite sharp, and it's quite hard. And then now worries me that the branch, I am struggling to wire, and if I cause a problem there with the venture catheter, then obviously there is no chance for me saving that branch. So I tend to use a lot less as a venture catheter now. We previously did. I don't know what other people experience. Do you use venture catheter? I haven't used it for maybe at least 2-3 years or something.
Venture is great, but also the Supercross family of catheters are another alternative. I don't know if it's available in Pakistan, but those micro catheters also have some bends that are angulated, side branches are always a challenge, so many different techniques. Now, in the future, there's a robotics company that gets you a very good access to the right to the side branches. So as we progress to robotic PCI, inshallah, one day Pakistan will have that as well, because you can do remote PCIs, and that could be a great thing for the country over long term. It's a capital issue at this point, but the side branches can be done with an automated joystick. So that's the future, but in the meantime, Supercross catheters are also a good choice.
Okay, I'll let you go to live case. Thank you.
Great. That was great talk, and we all been through that. They're still struggling with the catheter, the stents, and the guideliners. So maybe we can have a next talk with Dr. Tariq Abbas. He's from the Multan Institute of Cardiology, and he's going to be talking about keeping the jail branch open, modified balloon technique. Can you do the slides, please?
Bismillah ar-Rahman ar-Rahim. Thank you very much. Probably this is the last talk, and I must congratulate all the team, especially Professor Hanif Bashir and the President of Interventional Cardiac Society for arranging such a nice meeting for us and exchanging the ideas. Is basically, my talk is keeping the jail branch open. the technique is mostly used by our Japanese and Chinese colleagues, and they demonstrated it in many ways. So I summarized all the, next slide please. Okay. Thank you. Approximately 15 to 20% of PCI are performed to treat the coronary bifurcations, and PCI of the bifurcation lesions is technically challenging. And the selection of optimal strategy is still for the true coronary bifurcation, that is Medina 111 or Medina 101 or 011, lesions remains controversial because of the variability in side branch disease and the desire to preserve the patency of the side branch. The one stent strategy in many studies and a lot of literature, they are showing that one stent strategy with provisional side branch stenting is a superior to elective two stent strategies in most of the cases. But in special cases, you have to plan upfront two stent strategies also. And a modified of the provisional stenting strategy called the jail balloon technique is designed to reduce the side branch occlusion. So the various method has been, we are using in our cath lab daily practice. The most commonly used method is the jail wire technique. We jail the side branch and then stent and jail it. The method of occlusion of the side branch is either a shift of the plaque or carina shift. So if the jail wire is there, we can reintroduce another wire and we can track the side branch and open it easily. And in most of the time, it keeps the side branch open after stenting also. But in some time, it gets failed. And in one study, the COBS2 registries has shown that 8.4% lesions of the side branch occlusion reduce the TME3 flow has been observed in provisional stenting. So out of that, 13.9 recovered spontaneously, but in half of the cases with side branch intervention required. And still quite high number of side branch remain closed, and sometimes they behave catastrophically with the intractable arrhythmias and pain and myocardial infarction occurs on table or when you shift the patient in the CCU. So this is a very good technique if we master it to save the side branch. But many operators had done many ways and many modification has been advised for that. You keep a side branch, wire the main branch and then wire the side branch and keep the balloon, a long balloon in a side branch and then stent the main branch. And the technique is you keep the proximal end of the side branch just proximal to the stent and then see the response after putting the stent. If the side branch is open, you just gently dilate the side branch balloon at 2 to 3 atmosphere and take it out and then do the pot. And if the side branch get closed or compromised, then you just dilate the side branch balloon fully and take the side branch balloon out. And but the important thing that before dilating the side branch, you keep a short balloon in the main in the stent so that you can do the pot immediately after that without distorting the proximal end of the stent because of the inflation of side branch balloon. So this is, if we combine these two methods together, you keep a long balloon in a side branch, dilate the stent, deploy the stent. If the side branch is do not compromised, then you just gently dilate the side branch balloon and take it out and do the pot. And if the side branch is compromised, then you fully dilate the side branch balloon and keeping the balloon in the main branch and then afterward do the pot. But a little bit modifications has been suggested in by many operators. The one modification is that you dilate the side branch balloon minimally so that after doing the dilatation and deployment of the stent, the side branch balloon squeezes to the main branch and keep it open, and then you see the response. And if the side branch is open, then you take it out, the balloon easily, and do the pot later on. But our Japanese colleagues has suggested another modification in that, because there is a great chance of distortion of proximal end of the stent, and it will become difficult then to track balloon for the post-dilatation or pot technique. So they keep it a smaller balloon instead of a longer balloon, and they keep the balloon a little bit distal to the proximal end of the stent, and the little a short segment of the balloon in the side branch, and then they dilate simultaneously the both main branch and the side branch balloon, and then they take out both balloon together at the end and do the pot as a final steps. If the side branch is compromised or have some dissection, then always you can rewire the side branch and do whatever, either T or cool or the tap stenting to get rid of the lesion in the side branch. So this is the case of LED diagonal side branch stenting, that you keep the balloon in the side branch and stent the main branch, dilate the both side branch balloon and the stent together at the high pressure stent balloon, and then take it out and do the pot. And this is the case, another case with the left main circumflex, and this small balloon is kept in the circumflex branch and the stent across the circumflex in left main to LED, and dilating the both and then taking it out and do the final case. So that's the last modification done by the Seattle and the groups, and they have shown in one study that eccentricity of the proximal end of the stent is reduced by doing this technique and doing the final pot, and the reduction in the chance of edge dissection also. And the no side branch occlusion, one series is presented by Dr. Seattle in 254 cases, and the success rate is almost approaching to 99%. The only a minority cannot be recrossed. So the take-home message is the significant side branch should be protected, and the wire protection alone may still result in occluded side branch. The protection of side branch can easily be obtained by jailing or modified jail branch balloon technique, but the jail or modified balloon jail balloon technique should be avoided in a heavily calcified vessel, because if the balloon gets stuck or ruptured, it will be very difficult to take it out, and it will be a great emergency. So you have to think before applying this technique. Thank you very much.
Dr. Tariq, in the end, you are not doing kissing. Would you do kissing in the end?
Yes. If kissing, if you think that kissing is required, you have to do the kissing, but in some cases, because not in all cases.
If you use a inflated jail balloon and then you pull out, definitely the struts are distorted at the level of the...
In modified jail balloon, they are doing kissing, but in the conventional jail balloon, they are doing only parts.
Okay.
So if I may say something, I mean, this is just a technique of keeping the side branch patent. Once you've achieved that, then you apply the usual bifurcation techniques which you have. Great, sir. Real, very nice talk. Thank you very much.
So I think, Sohail, the only thing I would slightly suggest that I do is the technique is called jail semi-inflated kissing balloon technique. So let's say you got a 3 millimeter LED and you got a 2.5 millimeter diagonal. I would take a 2.0 balloon in the 2.5 and inflate it to only 1 or 2 atmospheres, and it's smaller, it's not beyond the proximal edge of the stent. And you deploy the stent, and the side branch will stay open. And at that point, you will deflate your balloon, take the balloon out. If the side branch is still patent, you'll take the wire out, and you will then go, the balloon that you have in your stent, you will go to its nominal pressure. So you do the high pressure initially, so let's say you go 14 or 16 initially, and then when you've taken that balloon and wire out from the side, then you just go to the nominal pressure, which is about 12, and that takes care of that most of the time. Now, you know, the kissing balloon, you would have to then re-enter from within the stent into the side ostium to do the kissing balloon. You can't do the kissing balloon outside the gel, outside the stent with the jailed wire, because then you will distort the stent.
That's a great technique, Tahir, Naeem. I do that also. So the aim of the semi-inflated balloon is just to keep the side branch patent. And this balloon never gets trapped outside the stent. So it's just there to keep the side branch open. You deflate, pull it out. You do a pot after that, so that you can increase the angulation and make your wiring easy, because you don't want to go under the struts. So you do a pot of a sort, and then you recross and treat it like any other bifurcation. Yeah, that's it.
I don't really go into, so if the side branch did not occlude more than 50%, if it's like 20-30% at the end, I will just do the pot. I will just go up to the nominal pressure and just leave it alone. And almost 90-95% of my bifurcations, I'm just doing it like that. And what I'm finding out is that I'm not having to go from within the stent into the side branch and do kissing balloons as often as I used to do before. So I think the gel semi-inflated kissing balloon technique is here to stay, and at least for my bias, I like it.
So you inflate the stent with the semi-inflated side branch balloon, then you do a post-dilatation, and you get the distal, you do this distal approximation properly, then you can pull out, do a pot, and recross or whatever. So you need to make sure that you keep the balloon there when you do your post-dilatation also.
No. So let me just repeat this. So you have you're deploying your stent, and you got a wire in the side branch, and you put a balloon which is smaller than the size of the artery, or it is 1-to-1, and you inflate it only at 2 atmospheres. And then you go up on both. And then once you have gone up, you deflate, and then you look at your side branch. If it is patent, then you're going to take the balloon and the wire out of the side, because that's jailed. And then the balloon in the stent is still there. You're just going to go up to the nominal pressure and deflate, come out, take a look at it. If your side branch is good, you're done. Now, if the side branch is 70-80%, then at that point, you're doing your traditional bifurcation side branch. So you're going to have to take another wire. This wire is probably the one that you use is probably now not worth going into, but if it can, you will then access the side branch from within the stent and do a kissing balloon. The only other point I wanted to make for side branch access was was the last time I wanted to take. So if making the angle is one of the most key parts to get into a side branch. So let's say if you have a 3-millimeter branch, main artery, I like to make my angle of 3.5 millimeter or 4 millimeters. So the idea is that when I flip it, it dips into the side as opposed to making a very small curve. And I found that very, very useful over the years. So just that part itself really helps in getting access to the side branch.
So the curve on the bend on the wire is based on the diameter of the vessel.
Yes, and it's just slightly bigger than the size.
So
that way, when you move it back and forth, if it finds the branch, it dips into it, and you can see that instead of trying to push it, it dips into it.
Yeah. So the back end of the curve is against the other wall.
Exactly.
Yeah. Okay, so let's
one
go
question,
back to
sir.
RIC.
Sir, one question. Sorry,
I think it's time for the second session
also.
also.
Question. Excuse me, sir. So one question here from
please.
Dr. Naeem. It was excellent technique explained by Professor. I just want to ask one question here. For which type of cases we need to just select this jailed balloon semi-inflation technique, or it's been just a decision of the wish for every case having the side branch stenosis, or we're going to save it in procedure? What type of cases we need to select for this procedure? Is there any specific criteria, or it's been decision of the wish we can just do this?
I personally would think a vessel which I would have difficulty in rewiring after the stent deployment, and which has angles or which has stenosis which could become totally occluded, which I'd have difficulty in recrossing. So those are the places where I'd choose them. Because many times the side branch has no issue with it. Even it gets pinched, you think you can get across it, but sometimes when you think it's too valuable, or it's too difficult to recross, maybe I'd use this technique.
Thank you.
I agree with Sohail. The only thing is, again, if I'm in Pakistan, that's exactly what I'm going to do. Here, I'll probably do this most of the times, because sometimes you have a normal looking side branch and it's going to get pinched quite a bit. And with this technique, it doesn't really get pinched. And you know, extra balloon is a cost, but it's not as big an issue as it would be if I was doing this at the doctor's hospital or Sheikh Zayed or National Hospital. So again, a lot of things, what I do in US is not what I'm going to do when I'm in Pakistan. So just have to be cognizant of that.
So that's very relevant. So if cost is not an issue, you should do it a couple of times just to get the hang of it. Yeah. So I think we start the next session, and Najeeb Bashir and Dr. Aslan will be the moderators. So we request them over. And Tahir Sahab, let's leave the podium.
Thank you. Thank you so much. Okay, good morning. So finally, we are coming to the last session of the day. And I would like to invite Arslan, so he's here. He's going to be co-moderating with me. And let me call my panelists here. So request Professor Nadeem Rizvi, General Kiani Saab, Dr. Abid Amin, Professor Hafizullah, Professor Zubair Akram, Fawad Farooq, Ishtiyaq Rasool, Mahmood Al Hassan, if they're here. So, okay, so if I can request Dr. Nadir Khan to come up, and also Dr. Abu Bakr Sheikh, please. Okay, so can we go? I think we are going to start this session. We are going to start with the live case from RIC. There will be a new case, and we also get an update for the previous case. And then we are going to move on to the fellows' best cases, and finally the closing ceremony. So,
they use the 3.5 non-compliant balloon.
So we will do LED as well? I don't think so.
No, I don't need
3.5 circumflex.
Yeah, just the balloon, just for stop and program technique.
Dr. Chen, can you hear us?
Yeah, I can hear you.
So this is Bashir, and Dr. Aslan is with me also. So if you could tell us about the case and what you have done so far, please.
Okay, so I am Dr. Hamid. I am assisting Professor Chen in this case. We have a very nice team. We have Nawaz and also we have radiographer Wes. So this is a case. Can you go for the first shot, please? So this gentleman, 62-year-old gentleman, he is hypertensive and a smoker. He presented a couple of months back with angina CCS2/3. He has a distal circumflex osteal disease, as you can see, a large size circumflex. Next, please. So next, please. He has a moderate kind of LED disease, approximately 50 to 60% stenosis over here, and his right is normal. So he was kept on quite a bit of medical therapy. We gave him nitrates, beta blockers, and then we also gave him the newer ones like granulazine and Vasilema, but unfortunately the patient still has angina. And he says that when he walks about 50 to 100 yards, he feels a lot of chest pain and discomfort, sizable circumflex. So we discussed the case in the conference, to be honest, but since LED is not involved, so the heart team decided as if the patient is still symptomatic medical therapy, he's a candidate for PCI to circumflex ostium. So after a lot of deliberation, because ostial circ, as you know, we might have to come into the left main, we might jeopardize the large vessel LED. So we used all those medications and lifestyle modification kind of, but still the patient having angina, so we'll have to, we did bring it away for this case, and we have the honor of having Professor Chen conduct this interesting case.
So, sorry, 1 second. We have some our panelists on virtually as well. I don't know if they're here. Dr. Javed Ahmed and Mohamed Agred from UK and Dr. Shahban from Italy. So, can you show us the spider view again, Leo Caudal?
Yeah, sure.
Epicaudal, please.
Epicaudal, yeah.
This one. Yeah.
Right.
Okay.
Epicaudal is the best view to
So-
separate the sun flash from RID.
Let me get some
Yeah,
opinion from the panelists, how would they approach, and then we can go further and ask you what you have done so far. So, Professor Nadeem, what do you think, and what will be your plan in this case?
Yes, I think as usual, in this case, normally nailing the left circumflex is a bit difficult. I'd probably use an IVUS to see how much left main is involved. So probably this is one of the rare cases that I probably go Colot. I think upfront two-stent strategy using a Colot. Nailing would be difficult because I think the left main would be involved and you would get a significant pinch in LAD. So I'd probably go Colot or DKC.
Dr. Azarkani, what do you think? How
He's
about
going
you?
for two-stent strategy, one of the experts. He said that LED
I
left main
think-
will be in. But we can show him IVUS.
Hi, Russia. After angiography, we also check IVUS for both RID and sun flash. Do you want to see IVUS image?
Let me get just a couple of opinions from here, and then we can proceed to the IVUS. Yeah. General Azarkani was going to say something.
Yeah, I think I would agree with Professor Nadeem Rizvi. I think go for the upfront. I think kill out and do the IVUS, see how the left main stem and how the ostium of the circumflex and the LAD is, and then go accordingly.
Nadir?
Well, I think that imaging is of most important here, and the strategy should be decided after we have done the imaging. And if the LAD ostium is not heavily diseased, we could go from left main to circumflex, provisional, and tap as a bailout for the LAD if the LAD goes down.
Professor Fizullah, you have anything?
The circumflex seems to be bigger than the left main stem is. So of course we cannot leave it alone, and the best strategy would be either DK crush or Coulot.
Dr. Zubair?
It's such a big, circumflex, and obviously it's a tight ostial stenosis, and I suspect that left main also is, involved. And there is a discrepancy of the circ is much bigger in size and than this LAD. I'll go with the Dr. Nadir's approach. First of all, Coilot, crossover from circ to left main. Either it can be a Coilot at the end or it may be a reverse tap.
Dr. Ubayyad, are you there? Can you hear us? Dr. Ubayyad al-Shumeri?
Yeah, I'm with you.
So can you please, what would be your strategy in this case?
I definitely will do the IVUS guided PCI. So this will tell me whether nailing or stenting over will dictate everything when I do the IVUS.
Okay, thank you. Dr. Chen, please go ahead. You tell us what.
Oh, thank you for panelists for your comments. So let's show you the IVUS image. Please, circumflex.
Circumflex to LED was.
Circumflex
Run that
IVUS.
loop. First loop.
Yeah. Can you say IVUS image?
It looks like the circ is like ectatic, proximal and mid portion is a little bit ectatic.
So this is the circumflex pullback, IVUS run. So we have a volcano, so this is the circumflex pullback run. We are coming back from mid circumflex. So this is the LED.
See some extra eccentric plaque.
Can you slowly pull back, please? Just show us the proximal circumflex and the LED bifurcation.
Yes.
Yes.
Yeah.
So this is the circ?
Yeah. No, little bit proximal. Little bit proximal. Yeah, this is osteo, not osteo, is the proximal circumflex. Can you see?
Yeah, we can see it.
Yeah, it's a cranial level, so from the angiography as well from IVUS, so the circumflex is almost perpendicular to left main. It means the bilateral angle greater than 70 degrees. I think this is a good chance for T standing technique. This is the first, I was wrong. So let's switch to I was wrong.
LED I was wrong.
Already I was wrong.
So did you look at the left main? You couldn't see the
You will show it
pullback
in
was
the
a quick one.
LED gun.
Yeah, I will show you the left
Okay,
main.
the LED. Okay.
Is the This is a RID, so it looks like RVD is around 40 millimeter, right? But less plaque burden, but not too much. Here is the proximal RID, circumflex is coming. Here is the POC area, very less plaque burden. Only 20 to 30%. Yeah, circumflex is coming. Can you see circumflex? Yeah, keep moving. Right, keep moving.
Yes,
keep
please,
going. Yeah.
That's a crime.
Yeah, that's a kind of level. Keep going. Yes. Yeah, here is the distal left man.
Okay.
So we have the minimal loop area is than 10 millimeter square. Keep going. Yeah, to show the whole length of left man. You see? Yeah.
Less than 50%.
Okay. Here's a proximal left man. Left man is pretty short, but angiographically, you know, the left man looks like smaller than circumflex, but from iris, so the left man is pretty big. So here is a minimal. It's a greater 10 millimeter square. So it's a very less a plaque burden at the proximal ID and the left man. So this is what we are working. So Bashir, so do you need to take second round of consensus panelists?
Okay.
So from the academic, will it change your strategy?
Yeah, let me ask Dr. Al-Shamari, what would you change your strategy, or what would be your strategy based on this IVUS images?
Definitely, it enlightened me that I have to stand the left knee. The nailing the circumflex will not be an ideal solution. And given the size, we may go with DK crush, the stenting, the left circ to left main, then the crush the LAD. I don't see the rest of the LAD, only I see the proximal part. The transmission image is not perfect in my side, but this is what I would do. Just choose the main vessel, the bigger one as a main stance, then they crush here, in this case, the LAD.
So you would still go with two-stent strategy?
Oh yeah, those stent strategy. It's disease listening.
So what would be your preferable two-stent, DK crush or Dr. Chen is there, so everyone is going to probably say DK crush. But
yes, I agree. Yeah, this is what I would do.
Nader, would you change your strategy? No. So I guess, tell us, Dr. Chen, what is your plan? I guess while you are there, everyone want to do DK crush. They want to see how you do it. So that's what the consensus is. Although there is a size mismatch, but it looks like lactatic vessel. So it will be interesting to see what size you would be using from left circ to for the side branch.
Thank you, Basha. You know, from angiography and IVUS, so the middle portion of circumflex could be defined by positive remodeling. So I'm sure the patient had history of ACS, that's true. And because, you know, for any given bifocal lesion, it could be defined by greater than 50% diameter stenosis in both vessels. So, but from angiography and IVUS, so RID has diameter stenosis less than 30%. So exactly, it could not be defined as Medina 111 bifocal lesion. It should be defined by Medina 001 bifocal lesion. So typically, it's isolated osteocircumflex lesion. My strategy is that I'm using cutting balloon to prepare flex lesion. Then,
so what wires did you use?
I will use stop and pull back technique. Okay.
So you have workhorse wires in both circ and LED.
Right.
BMW
circumflex.
BMW.
So BMW wires. That's 15 cutting balloons. I did not pre-dilate the circumflex.
Okay.
So I want to take a photo for you.
So what is it, 3.0 or 3.5? What balloon size is?
So 315 cutting.
Yeah, 315 cutting balloon. So from the angiography, we can say distance between two wires is about 2 millimeter, right?
Yeah.
So this is very important. You know, we don't want to cut in the I don't want to cut in the RID wire. So the minimal distance between two wires should be greater than 1 millimeter. I think, can you give me a small test? Small test. Okay, perfect. I think it's perfect.
Yeah, looks
so it
good.
means the process in the left going up from 6.
So what kind of pressures you do on cutting balloon? There was yesterday some discussion. Some people go up to like 12, 13, and they were saying some were going up to like 18. So what is your preference of how high you can go on a cutting balloon?
I could not hear very
So what's the pressures in the cutting balloon you do?
Okay. Usually, you know, this is third generation of cutting from Boston Scientific. Usually we start from 6 and watch 1 to 2 seconds and then up to 10. That's enough.
Okay.
So maximum he goes 10 and he starts with slowly upward balloon dilatation. He stops at 4 to 6 and then have a look and then he goes maximally to 10.
Right.
So what about if it doesn't open that well? Do you have you used higher pressures or not?
Yeah, usually I prefer to use low pressure.
Okay.
Can you say after cutting? So the osteocentric flash looks good. Natural.
So if the cutting doesn't open up, then what's the option?
Really?
He's asking. He's asking.
Asking? No, I don't think so. Can you back to the previous one?
Not in this case, generally.
Oh, generally, okay. Yeah, you know, and for cephalic, a cannibal should be inflated at least 14. But from I was, there is at the proximal surface is the fibrostic plaque, so it's easily to be inflated by cutting. So now, Basha, can you say angiography immediately after cutting?
Okay, so let me ask from the panelists what size stent they would be using from circ to like for crushing the side branch stent. Nadeem, what size stent you would be using here, because circ looks really big.
Yeah, 3-5 balloon in already. Yeah, actually, you know, Bachi, according
this,
to the IVOS,
I think by IVOS,
vessel diameter is 4.2. So I prefer to use 3.75 stand, right?
Yeah,
5 balloon. Oh, AD, right, balloon. So I prefer to use 5 stand in some flat. Right now, because I'm planning to do stop and pull back technique. I think this is a very old technique, very, very suitable to this particular case. So first of all, I will use 3-5 balloon in the left main crossover to RAD, and then I will...
Ostial nailing, he will be trying a technique known as the stop and pull back technique. For that purpose, we are taking a 3-5-15 balloon in the LED, left main to LED, and then we will take the stent in a circumflex.
Okay, right. There is a comment from the audience just from Dr. Najeeb.
Okay. Because of ectasia, would have any impact on balloon sizing and the inflation pressures? Because proximal circ doesn't look normal vessel, looks ectatic.
Yeah.
So will that have any impact on balloon
sizing? That's what
and
I've been pointing out. There is ectasia. So would you go by the size of ectatic vessel, which looks like almost 4-5, and obviously that area is diseased ostium, but rest of the circ. So size is going to be, because if you're going to end up your stent in the ectatic vessel, then you probably have to match to the ectatic vessel, maybe post dilate with a bigger balloon to match it. So Dr. Chen, so what size stent you are planning for the circ to left main?
It's 3-5 for some flash. This is the 3-5 balloon.
So we have placed a 3-5 balloon in the LED, and we are not doing a 3-5 stent for the circumflex.
Right.
Oh, okay.
3-5 stent.
Give me 3-5 stand is the LED wire.
18 दिखाएं?
Yeah, let me double check.
18 और 23 दिखाएं, 3-5.
So the circ on IVS was what, 4.2?
दिखाएं और 18 दिखाएं.
Pardon me?
The circumflex on the IVS was 4.2. What was the size of that ectatic segment? On
yeah, actually Reference vessel diameter for proximal third is around 4.2, that's all.
Yeah.
Please stand.
Stand, please. 23, C5 23 or 18?
18, 18.
C5 18, please.
18, just 18.
Dr. Bashir.
So we are taking a C5 18 stent for the ostial circ. And obviously, with the help of IVUS, if it needs post-dilatation, we can definitely expand it up to 4.2 or 4.5 even if that is needed.
Yeah, that definitely you're going to need to expand that because it's a bigger vessel.
Dr. Bashir, is there a flow in the left circumflex kind of branch or after the cutting balloon, last angiogram?
I'm sorry, I didn't hear. What did you say, Ved?
It's not clear in my images here, but it sounds to be there is something at the left circumflex, last angiogram, post the cutting balloon.
Yeah,
Is there an
I saw that too. There is, looks like there is a fistula. There is a small branch coming, and then there seems like emptying somewhere. I saw that in the previous picture also.
Actually, after cutting, no dissection. You know, Bashir.
No, I know, but what Wayed is talking about is there is some free flow going from that area. If you pay close attention, just below the guide, you can see there is some free flow going from that branch. I thought it's probably fistula over there. Can you appreciate that, Hamid or Dr. Chen?
I think that just below the guide, is there any problem?
No. It's a small branch.
It's just a small branch, not as much issue.
I know, but it's a small branch, but there is some free flow at the end of the branch. That's the question was probably small fistula over there.
Sir, it is.
Yeah, you know, it's also exists here at the baseline angiography.
Sir, it is probably the contrast backflow from the guiding that you can see there. It's not actually coming from the branch.
My question is that if you're doing imaging and you're doing cutting balloon and the 3 millimeter cutting balloon opens up, then you know you've fixed the intima. Then I think in a 4.2, the general rule is you put a 4 millimeter stent if you're going into the left main. And at a low pressure, you don't need to deploy at a high pressure, just go 6, 8, 10, 12 or something. And then you can then expand that stent up to 5 in the left main. Because the cutting balloon costs money. And if you've done IVUS and there's less than 270-degree arc or if the calcium is not very superficial, then I would just balloon it because cost is also an issue here. Because if you do a cutting balloon, then a stent.
I'm sorry for interrupting your presentation.
No, go ahead.
You know, now stand in the circumflex, I slightly withdraw the ID balloon. So let's take a photo, take a picture. Okay. Picture?
What is good? Okay, picture now.
One more. Okay. No, it's fine.
Okay, it's okay.
Dr. Nadeem was saying that since we have already seen with IVUS the vessel was 4.2, so maybe we could have used even 4.0 stent and then post-dilated with a 4.5 to make sure that's adequately opposed to the wall.
No sense. Okay. So now, can you inflate the balloon, left main balloon? Yeah, inflate.
So we have pulled back the left main balloon and we are inflating it now?
Only 6. 6.
6?
Yeah, 6. Okay, inflate the stand. Okay. Deflation balloon. Okay, perfect. Okay, done. So,
stand down?
Yeah, deflation. So, but you can see the whole process of standing is called the pullback. Stop the pullback. So I inflated the left main balloon as a loop just by 6 at the most sphere.
So
and withdraw the circumflex stand very gently, gradually. So once the circumflex stand touches the left main balloon, so it could not be withdrawn, right? So immediately, simultaneously inflated the circumflex stand. From the angiography, so the ostial circumflex was not fully expanded. So next step is to do post-dilate.
So that's interesting. Has anyone ever used this kind of a technique, like inflating the balloon in the left, in the main vessel, and then pulling back the stent and doing that? Did you see
actually,
what?
Okay, go. Okay, go ahead.
Can you give the mic, please?
Okay. Give me 3-5.
I think, Hanif, it's a great way I just
know, it looks
noticed,
like.
because this way the crush
Yeah,
will be towards the circumflex. And if you just pull it back, inflate, the crush can actually be anywhere around the vessel. So it's a great modification to this technique.
No, I know, but I'm saying has anyone used it? Because I have not
never really thought of it.
Najeeb, you have.
And I've used it. The trick is slightly smaller size balloon, low pressure inflation. So you have like 2-3 struts in the left main. And obviously, I've used it.
But most of the time they suggest that when you're crushing, you need a bigger balloon to make sure it's properly crushed. So I guess you have to change it, then you bring back and then go back with a bigger balloon. Or what do you do?
Because there's not a lot of atheroma in left main. It was just the ostium of circ. For this lesion is suitable. But there's a lot more atheroma in left main now.
Bashir, the aim of this technique, I've done this, is to just ensure how much you are going to crush. So it is not a matter of crushing, it is a matter of, because when you do balloon inflation, you sometimes the stent slips down and sometimes it slips back. This technique, while you are inflating and pulling back the stent, and you've got another marker, which is the other balloon in the left main LED, you exactly know how much you are going to crush. So the aim is to know exactly how much stent is in the left main.
During extension.
But you have to use a smaller balloon, otherwise it won't be able to pull. But my concern was to crush that stent. Okay, over here maybe there's not much disease, but to crush you really need a bigger balloon.
Yeah, of course. This is not for crushing. This is barely to see how much of the left main, how much stent is in the left main. You see, now he inflates. So you know exactly how much stent is in the left main.
I explain some technical point of view.
I'm just like
so
guessing,
from this view, you can see there is at least 1 millimeter distance between the mark and the stent edge. So when a left main stent was inflated, can you see slightly withdraw the circumflex stent? So it means the proximal circumflex stent could not be crushed by the left main balloon. Is that clearly? So no crush at all.
So Dr. Chen, are you going to use a bigger balloon to crush the circ stent, or are you going to just use the same balloon for crushing this stent?
No, crushing the stent.
Yeah, actually, now I'm using the same size.
I think they're just doing the osteal, they decided not to go with 2 stents, is what my understanding is.
So the purpose is we are doing osteal nailing. The purpose is we are doing the osteal nailing, not doing the 2-stent strategy.
Right.
And the purpose of the balloon is twofold. One is to appropriately position the circumflex stent, and secondly, obviously, to avoid the carina shift as well.
Okay.
We will have a balloon in the left main, so any plug shift and carina shift will also be reduced.
So are you planning a single stent strategy?
Yes, we are single stent, osteal circ.
Yeah, done.
But you were in the left main, so...
I studied from one stent procedure. So, but I have a post-dilated stent, and I always keep the left main in the position. In terms of the stop and pull back technique, we still have some variants. For example, if there is a dissection or slow flow in RAD, we can use either cutting balloon or even we can transfer to traditional T-stent technique. That's very
what size
simple.
balloon you use for post-dilatation?
3.5.
3.5. The same the sense right at present, and we'll have a look and see how can we modify further.
Okay.
No, but isn't your stent in the left main also?
No, not yet. After that, I will show you the iris. Okay. Take photo. Take picture.
It looked like the stent was in the left main.
Go ahead.
So I think we'll have to do a 2
I think it's perfect. Is there a dissection at the osteo already? I don't think so.
It's only 1-2 struts did come into the...
Right.
Yes, sir.
Maximum 1 strut.
So there's maximal of 1 strut that comes up into the left. We confirm it with the iris.
Yes.
So don't you think that you need a bigger balloon to post-dilate instead of just 3.5, because the vessel was 4.2, the circ?
Yes, we will do that. Iris run and then we'll do that.
after IVUS.
Can I have a couple
Probably
of questions
we
from
also
the chat?
needed
So there's a question from the audience, yes.
So
Yeah,
the
this
first
is-
question is that what are the lesions where we prefer cross-sewer stenting as compared to ostial stenting? One thing. Another thing, one
Yes.
area that is called uncover stent studs, and that how much it affects the future short-term as well as the long-term outcome, because we have a couple of studs which are hanging in the left main, and these are very difficult to get into endothelialized because they're at the carina, right? So these are the questions to Shen. That and another thing for uncovered stud area is OCT is a better as compared to IVUS. And if we have an IVUS down there and we want to really nail, why not to put the IVUS in the LAD and nail the stent at the ostium of the circ rather than putting a balloon?
Yeah, actually, you know, for isolated symphylis or isolated osteoid lesion, the stop and pullback technique only can be used if the distal left main plaque burden less than 50%. That's the only indication. The second point, you know, I have explained when we inflate the balloon in the left main and simultaneously withdraw the stent from circumflex. So we have to very carefully to define the position of proximal mark. For any kind of stent, there is at least 1 millimeter distance between the proximal mark to the proximal edge of the strand. This is the key point to define the stent. So now I'm going to recheck the IVUS for circumflex.
So Dr. Chen, which stent you used here?
Eucalyptus.
Which technique?
Eucalyptus, which stent?
Oh, which stent?
So we use the Eucalyptus stent, obviously the sponsor in this case, so we have taken
So-
a 3-5.
So what is the...
Switch to IVUS image.
IVUS image live, please.
Yeah.
So
Can
what-
you say IVUS?
I mean, this is that Greek technique that I was describing yesterday. That if he had used a larger balloon at a low pressure and pulled the stent back, then he would have avoided going into the left main. In this way, we're using a smaller balloon, then I am sure that there are more than one strut in the left main.
Can you show the IVUS on the bigger screen, please?
So can you see the IVUS?
Yeah, we can. Yeah, now we can see on the bigger screen, yes.
Okay. Close to distal edge of stent. I think it's the diameter is around 3.25. I think it's good enough. Good enough. Good enough. So let's take care of the osteocircumflex. I think it's big enough. Okay. Okay. Can you see?
Yeah, we can.
Let me. Yeah.
But it
Here
just
is a
jumped from circ to left main. I'm not sure whether the stent is hanging in the left main or it's just at the ostium of the circ.
Yeah, let me put the IVUS a little bit distally into the circumflex.
We are pushing it back just to see again.
Because this is manually pulled back.
Yeah, I know.
Okay,
pulling back
can you
again.
see?
Yeah.
So focus on the cranial level. Okay, just jump out from the.
Yeah.
Okay. Here is the osteocircumflex and jump into the left main. So I think only one strut in the left main. So left main is very big, no dissection in the left main
We
too.
only have one strut in the left main
Okay.
based on this IVUS. And do we take NNC 375?
No, not yet. We still need to check LAD IVUS.
But Hamid, don't you think that you will need a 4.0 instead of 3.75? We know the vessel size was 4.2.
So what we are going to do now, take an IVUS from the left main to LAD as well, and then we think again and see. Probably you may be right, we may have to take a bigger balloon.
But even angiographically, it looks like also circumflex was not expanded very well. But I was sure. Can you measure the minimal lumen area for osteocircumflex?
Okay, MSA for the circumflex, please, at the ostium, where it was slightly on the lower side.
IVUS.
Which hand?
Hanif, I think in this case, because of the doubt, because the IVUS jumps suddenly, this is a good case where a good stent boost or something like that in an iliocaudal, deep caudal, and deep LAO, you would be able to see how many struts there are in the left main.
It looks like there are a couple of struts in the left main, definitely.
I was because it jumps, and one way is to use a
good enough.
old balloon and put it in the LED.
Normally
and
we
you'll
need
know.
to use 3.75 to post dilate.
So we got an MSA from the left main to circ. You can see it being a 5.5. So it's a bit under, as you all know, but the MSA is quite good, as you know, based on different studies.
Okay.
An MSA of more than 5 in the non-left main is good enough for reduced long-term MACE.
Yeah, so sure, I was the
But
image.
still, we may be taking an NC balloon once we have left main.
Yeah. Now is the LED. LED I
So
was.
this is the LED pullback.
Okay. Recall. Yeah. Recall. So you say proximal ID, no dissection.
Here it seems like significant plaque there in the ostium.
Yeah, no dissection. Here is so only one straw in the POC area. I think it's beautiful. Okay. Here is the distal left main. Left main is fine. Okay, I think it's fine. So could you reimagine the minimal lumen area for proximal ID?
Can you run in the IVUS again, please?
Can you give the iris
Yeah.
run again?
Sure, I was.
दोबारा दिखाएं. Manual slowly pullback करें. हाँ आते रहे. So what we're going to do, we are going to show you the MLA on each in the ostial LED or पीछे or.
See here, it's go back a little bit. Here it seems like no. There are some struts there at the.
Short one. I prefer short one.
No, कैंची नहीं.
15.
इधर ले.
Do you have 12? Do you have 8 or 9?
8 हाँ छोटा है. 3.75.
No problem. I like it. Okay.
So this is MLA at the ostial LED level. So we have MLA of 5.6.
5.66.
Are you happy with that question?
Yeah, I'm very happy. So, Basha, now I'm planning to use a 3.75 short NC balloon to post dilate also show SIR.
Okay, so you are not going to do in the distal part of the stent because that's in the ectatic vessel and that size of the vessel was like 4.2. So I would be considering using 4O balloon instead of 3.75 just to make sure it's adequately opposed within the ectatic segment as well.
Yeah, but you know, the vessel diameter, it means the EM diameter is 4.2. So usually we do not use a full stent or full NC balloon to post dilate.
I guess
so
the
formula is that EM diameter multiplied by 0 point. So it should be 3.5 to 3.75. I think it's big enough. Also because of the it's isolated sunflat, also shows sunflat lesion. So angiographically, sometimes over-exaggerate the stenosis. Short NC balloon.
At the narrowest part, they were getting an area of 5 millimeters square already. So, and the other area of the circumflex, the stent was well opposed, may not be EM to EM 4.2 millimeters, but I think they'll be kind of overdoing it because the area over there probably is definitely up to 5.56 millimeters square. Then the narrowest part, they're getting 5. So, and, you know, you'll meet all the ultimate criteria for good outcomes if you just post dilate with 3.75.
So exactly, I agree with Dr. Noman Nasir. If there are two indicators which have shown an impact on long-term outcomes based on IVUS and OCT criteria, it is the MSA post-stenting and also the stent index, which is the ratio between the MSA and the distal lumen, distal vessel diameter. So if both of them, if the MSA is more than 5 and or more than 90% of the distal reference area if the vessel is small, and if the index is more than 90%, then it means that it's well expanded. So the MSA throughout the circumflex was more than 5, and at the ostium it was definitely a bit under, but it was still more than 5. So that is why we are taking 10.5 stent. and mostly we are concentrating on the ostium of the circumflex.
Is Javed or Mohamed agreed online? Dr. Javed, Dr.
There are
Mohamed?
two different criteria to define optimal distal left main PCI. One comes from subscale team. So after standing technique, so the minimal lumen area for SIR should be greater than 5. But from Excel trial by Dr. Greg Stone, they proposed 6 millimeters square for SIR. So after standing in this case, the minimal stand area is 5.6. It's bigger than 5, but a little bit smaller than 6. So this one we need to repost dilate. Okay, thank you.
Yeah, no, that I understand, but my only concern was in ectatic segment. I know in this case it seemed to be opposed okay, but you want to make sure that it's well opposed, the stent is well opposed to the wall. Otherwise, I understand that the area, if the area is good, then it should be all right. Dr. Wayyad, are you there?
16.
16.
So what's any comments from you?
About the durability of the ostial LAD, there is a disease that's also touched by a balloon when they nail the ostial left circumflex. And this is a nidus for restenosis. Then, when we pull back the wire of the LAD and reinsert a wire to LAD later on, a few months later, it might go in the protruded to the left main. I'd like to go with the to ensure the long-term durability is to do 2 stents technique to cover the ostial LAD that has already been touched. And the other thing, the distal half of that stent, I'm not talking about the MSA for that thing. It's talking about the opposition, and we know with the ectatic vessel we are concerned about the ectasia and more disease in future. So it's more opposition of that stent to the visual wall may have a better durability and prevent stent thrombosis in future.
Yeah, that was my concern.
One of the ways of poor man's way of finding out is when they were doing the NC balloon, they would just give a small puff, and then you'll know how much of lumen there is going into it. If there's TME3 flow in the LED, then you know there's 1 or 2 struts. If it's TME2, then you know it's more than 2 to 4 struts. And that's the way I find out how much. I still feel that there's more than 1 strut.
If you can show the image for the IVUS.
Question is very simple and basic. That is, when you are dealing with such osteal lesions, they are comfortable inflating the stent in single view, not checking it on another view?
Sorry, Bashir.
Ahmed. Yeah, so the question was that just putting the ostial, if you want to really make sure you are covering the ostium and not too much in the left main, is single view enough, or should it be looked at the another view before saying that you are placing the stent in the ostium?
Yeah, actually, I appreciate the comments. Model is the best view to separate SIR from
But you worked in the AP,
So we have reviewed the different views, but this is the last round of circumflex IVUS. Yeah.
Just need to be because they don't. Sorry.
Tell you how much the minimal stand area should be 9, I think.
7.4.
7.4.
Okay.
7.4.
Because there are only 2 struts in left main. If you post dilate with a lot bigger balloon, you will have foreshortening. So you need to be careful. You don't lose the ostial coverage. If you put a very bigger balloon in a 3.5 vessel, because there's only 2 struts, it will foreshorten.
Dr. Javed, you are online. I don't know how. When did you come, or did you see the earlier case? Do you have any comments, or what do you think?
By the view. Yeah, actually, the stop and pullback is now commonly used for true coronary bifocal lesion. But for isolated bifocal lesion with wide angle, and plaque burden in the main vessel less than 50%. So this is the chance for stop and pullback technique. But during the whole procedure, I think there are several key points. The first is we have to inflate the main vessel pressure at very low pressure, main vessel balloon at a low pressure, and simultaneously, very gently, very slightly withdraw the side branch stem. Once the mark, the processing mark touches the balloon, so we could not withdraw the stem at all. So then, slightly deflate the main vessel balloon and inflate the stem. Finally, I was guided. The whole procedure is very, very important. If there is any dissection from right to left main, or if there is any compromise of ostial RID, so we could use, we can transfer to a drug-coating balloon for RID left main, or even we can transfer to traditional T-stent technique. So, for traditional T-stent technique, usually we deploy one stent inside branch. That's all. So we have multiple choice. Okay. How the procedure should be guided by intravascular imaging. Okay. Now, I think this will be last shot.
Javed, are you there? Javed?
Okay.
Yes. Yes, I am.
So what do you think? What is your, any comments?
One more.
So the MSA, yes, I agree that it's good, reasonable, but I'm just quite concerned about these details in the distal left that has anything to do in future. Results will be shown here.
Okay.
Yeah, can you show the last spider view?
The spider view, please.
Yeah.
So we have finished the procedure. So this is the
Give me
spider
a few
view.
pieces of.
And the RO Coil, please.
So, Ishtiyaq?
Yes, I just wanted to add, my comment is that it's all about choices. If one is opting for a double crush, then I think it doesn't matter, you take 3.5 or 4. So, because with a ectatic vessel, you may have, with high pressure, you may have a distal dissection and dissection in the left main. But for this strategy, one stent strategy, I think the better choice would have been to take a 1:1 sizing, so then not to go to a high pressure, so that you can prevent distal and proximal dissection.
Dr. Nader?
Hamid, you've done the Iveston in the LED and shown us the MSA. Can we calculate the plaque burden in the proximal LED, because there appears to be quite a significant plaque there. So could you sort of go back to your Iveston in the LED and check the plaque burden there?
Yeah, sure. Last I was wrong for ID. Actually, we measured the minimal lumen area for ID. No more change at all after the.
Dr. Javed, are you there?
Yes, I'm here.
So I don't know if you saw the case earlier. Do you have any comments?
I just joined very late, I'm afraid, and if you could give me a little bit of the background, I'd be delighted to obviously comment on it. Thank you.
So it was, we are at the end of the case, unfortunately, and basically it was a left main bifurcation kind of a lesion, and they did Ivers. Ostial circ was more tight, and they've just put a ostial circ stent by placing a balloon from left main to LAD, and then just put a stent in the circ and post-dilated. Instead of going for a two-stent strategy, they decided to go for a single stent after Ivers, as the disease in the LAD and left main was not that much.
Thank you very much. So you have already adapted a two-stent strategy rather than a single stent, is that correct?
No, they did single stent strategy, only covered the left circ to ostial circ. Just putting a couple of struts in the left main and kept the balloon from the left main to LAD.
I think ostium doesn't look too bad actually. Yeah. So perhaps it has not compromised the ostium of the LAD if there are only a couple of struts, you see. And the stent size looks pretty good for the size of the circumflex.
Quite good. And we are only just, because of the technique, we are only one strut hanging into the left main. And the LED MSA after the end of the procedure was approximately 5.8 to 5.9 millimeters square. So the LED ostium is very much intact.
Can you see what's the ostium like of the LED? I missed the IVUS run.
Can you go back one image? Can you go back? Yeah, this one. So,
which run do you want to see?
No, this is fine.
Run would be from circ to the left main, but when actually there, one can easily assess the ostium of the LED as well, if I'm not wrong?
Yeah, they did. They already run the IVUS from circ to left main and then from LED to left main. And everything looked good. The ostial LED doesn't look that bad. The area was, I think, more than 5.5. So they decided to leave it alone and just do the circ to left main.
I agree, and angiographically, the LED doesn't look compromised in any way because the dimming flow is good, and angiographically doesn't look like the ostium is compromised. And I think I will stick to this single stent strategy and perhaps just need a little bit of more post-dilatation, and after that, perhaps it is done. To be honest with you.
Okay. Oh, thank you. Dr. Javed did a live case the other day. It was a great case. He has his own meeting, Complex Cardiovascular Interventions, and we have been working together and collaborating with Pakistan Live and PSIC. So his meeting is coming up in I think 2nd and 3rd September. Thank you very much for all your help and collaboration.
No, thank you. Just one last comment, Bashir. The only thing is, in this view, do you think the middle of the stent needs a little bit of more flare-up?
Middle of the stent, sorry, what?
I agree with
Dr.
Javed. Graphically, it looks a little, but we got an MLA of 7.3.
Any final comments from Dr. Chen or Hamid? I think, or looks like a great case.
So yes. So I agree with Dr. Javed regarding the ostial circumflex. We got an MLA of 7.3 in the end, and we were thinking about going 4.0, but Professor Chen said, okay, it might compromise the LED ostium as well by taking a bigger balloon. So 7.3 millimeters square, as you all know, based on guidelines, is good enough MLA for a long-term better outcomes. So that is why we did a 375 NC in the ostium of the circumflex stent and got an MLA of 7.3.
It's a great result, actually, given the anatomy.
Any comments from the panelists or audience? Any questions, comments? Yes, please. Mike here, please.
I think one thing that is...
So there's a question from the audience. Just 1 second.
Thank you very much, Dr. Bashir. This is Zahoor from Peshawar Institute of Cardiology. It's really a good case, and as all the audience as well as the panelists initially planned that this should be a two-stent strategy up front. However, it turned out to be a single-stent strategy. Indeed, this is seems to be more like a subjective thing. I would love to see if there's any data from their center in regards to the long-term outcome in terms of the 1 or 2 struts getting into the left main. Potentially, theoretically, it's a nidus for a future thrombus. So how would we deal that, number one? And number two, this subjective technique of putting a balloon in the left main and the LED and then pulling it back. One of my colleagues did point out that whether this should be confirmed in single view, one single view, or multiple views, or is there any standardization for this kind of nailing with the balloon? Thank you so much.
Ahmed, did you hear the question?
Yes, sir. So answer the first question regarding that one stent to two stent strategy. Obviously, if you look at angiographically, initially we thought to go to stent study, but I guess as most of the panelists did suggest doing an imaging in the first instance, so that did help. It did show us that the left main stem had not enough disease. It was less than 30-35% plaque burden. So as long as the plaque burden is less than 50%, the studies have shown that it doesn't constitute a geographical miss, and you can definitely take a single stent strategy. So the left main was at wall. That is why we took a single stent strategy, and we did that stop and pull back technique, in which we tried our level best to ostial nail the circumflex. And when we did the IVUS post-stenting, we did see one stent coming up. I agree with the comment, theoretically an uncovered stent has the potential of nidus of having a future stent failure event, but just a single strut maybe, I think we can get away with that. And dual intrathecal therapy is the course for this gentleman, because we have a significantly larger, although it's a larger size stent, but it is a very complex area. So that is why we'll be giving him long-term anticoagulation and antiplatelet therapy. I think inshallah he will keep good.
So one question here, one last question.
Last comment then before we move on to the next.
So here's Dr. Shib, excellent result been produced by Dr. Shain. My question is this, how many struts have been just acceptable in the left main if the IVUS has been shown as the 1 or 2 struts have been just left there in left main? So how many struts in the IVUS been acceptable first? And secondly, he just thrown a light on anticoagulation therapy to just prevent the future thrombotic event in the left main. Secondly, it can just also produce some hurdle if unfortunately patient LED is going to compromise in future and we are just left some struts in the left main. So what can be the best strategy just to produce these things?
Can I answer that?
Yes.
You see, it doesn't matter how many struts there are. What matters is the size of the left main, and they managed to get an IVUS without any obstruction. So if you can get an IVUS into the LED after you've stented and done an NC dilatation, you are fine. It endothelializes in such a way that the bench tests show that there is partial endothelialization of something which is hanging in the left main. So it doesn't really matter. The only problem for future is whether you can get into the LED quietly, and they did that with an IVUS. So if an IVUS or an uninflated large balloon, a used balloon can go easily after you've done or finished the procedure, then you won't have a problem in the future.
Yeah, but still you don't want to have too many struts in the left main
also.
Of
course, but it depends on how much big the left main is. The other point is the angle. It doesn't really matter what kind of, how many struts. The matters is that if you've got a 90-degree thing, then you can have 3-4 struts. But if it's a 70 or less or a very acute angle, then you can't afford even 2 struts, because then you will have obstruction. So the angle of the carina also matters.
If I quick word,
thank you very much.
Yeah.
Bashir, can I just comment on Nadeem's comments, please, if that's okay?
Sure, go ahead, quickly.
I think Nadeem is absolutely right, because the audience actually raised a very important question, the future of whether there is thrombosis. Left main stem are usually big and they are very forgiving vessels actually. And a majority of the stent thrombosis in left main usually because the patient discontinued with the therapy. I think mechanically, as long as you achieve a good MSA at the end of the case, and this blocking balloon technique usually works in majority of the circumstances where you got a balloon in the parent artery or the main artery and you got a stent in the side branch, you see, it means that there may be only 1 or 2 stents which are again dabbed or which are against crushed against the balloon, you know. So I think from thrombosis point of view, it will be very unlikely unless and until patient stops the antiplatelet therapy themselves. So generally, I mean, I've seen very, very rare cases of stent thrombosis in the left main as long as you achieve a good minimal stent area.
Just a quick comment, Nadeem, just a quick comment. You know, we end up jailing a circumflex and not opening the struts. So when we leave such a big vessel totally jailed by struts, what are a few struts across the vessel? To me, that's a non-issue. And to say if we have evidence, I mean, you don't have evidence for so many things. And nobody's looked at it. Maybe somebody would, but I doubt if it's such a big issue.
Okay, Abid, Dr. Abid.
Yeah, we can see that the ostium of the LAD is pinched and it has been partially ballooned. The future, in the near future, the event, the possibility of a future event will be high in such a patient. What do you think?
Well, there is some disease in there on IVUS also, but it wasn't significant. Again, the balloon they used wasn't really that big to really damage the intima. Yeah. Obviously, if you use a bigger balloon and that damages intima, that can initiate restenosis. But if you use a smaller balloon, which they did use, I think 3 which wasn't really that bad, so it should be okay. Shouldn't cause any problem.
You think the possibility of future event is
natural disease
small.
Can progress. There is a disease there about 50% or 40% can progress with time.
Bashir?
Yeah.
the LED has residual moderate lesion. Would you consider doing an IFR or FFR at this point?
I think IVUS, they have done the IVUS, either you do IVUS or FFR or IFR, and on IVUS they didn't think it was significant. It was a good size vessel, so I think it should be okay.
So I
yeah.
think IFR is a very good way of having.
That's.
I guess for they got an MSA, I mean, a lumen area of more than 4 millimeters square.
Yeah.
You can defer on more than 4 millimeters square. I think you can't intervene on less than that, but on more than 4, you can easily defer. There are the multiple studies where you could defer on more than 4. There was FFR have been normal with that.
Yeah. Okay, I think that's, we have to end. Thank you very much, Hamid. It was a great case and well done. Nice demonstration of osteal circ stent placement. Thank you very much. Okay, so we are going to move on to the last part of the Pakistan Live, and which is very important. And for that, I'm going to request Dr. Aslan Masood to come and do that. It's basically the case presentations, and the one who the chosen as best, he's going to explain all the details. But believe me, it was a very, very tedious process. We received over 120 cases. We sent all over different, like Pakistan, countries, other US, UK, 2 cases, and he's going to explain the process. But what I'm trying to tell you, it was a very difficult, and then we chose randomly the best cases from them, 25 which were selected, and now today the 4 best cases will be presented. I really want to thank Arslan Masood. He has really worked very hard to do all this, and I'm very grateful, and I'm going to ask him to really take it from here and work on that.